And may I request Soni ma'am to please come on the dais to chair the session. Dr. K.N. Tiwari sir, Dr. H.N. Pandey, Sudhir sir, Nilesh Mohan sir. Uttam, you are the moderator for the session. Salab Sinha sir, Ranjan Rai sir, Deepak sir. May I, so Uttam, please moderate with me. So we'll be starting with the keynote session for this this session, and that is by none other than Dr. Subhas Prasad, and he will be discussing with us triple therapy for glaucoma. May I request Subhas sir to please come on the dais.
Just a request, Abhishek. Can we announce the beginning of that we are commencing the session in the dining hall also? थोड़ा अनाउंस करवा दीजिए उधर. Many of the persons are in the dining hall. ऐसे रंजन भाई से अभी जस्ट भेंट हुई थी. हाँ, जैसा बुलवा लीजिए.
Good afternoon. I am thankful to Vihar Ophthalmological Society. This is a sponsored talk from Ajanta Group. They have contributed to this conference, and they have asked me to present this talk on triple therapy, which is new drug armamentarium, or you can say the combination of drug which is available in the market nowadays. We all know that glaucoma is one of the leading cause of blindness in elderly people, and the only modifiable risk factor is intraocular pressure. And medical therapy is just one which is started first to control the pressure, and if it doesn't get control. If it is not controlled with this, then we switch on to either laser depending upon the situation or surgery. So medical therapy or management is the mainstay of treatment of glaucoma. But there are challenges in treating glaucoma patients because of non-adherence, which is one of the most important reason of progression of glaucoma or patient losing vision, because most of the patients, they don't follow the advice and they don't stick to the treatment. And unfixed combination actually increases the schedule complexity because the patient has to put it so many times, so it decreases the compliance. And also because of the increased amount of preservative we are using with multiple vials, it increases the ocular surface problems. So another problem is if you put medicine and the patient is asked to put after half an hour, many of them will put one after another, so that will wash out the previous medicine, thus having less effect of the medicine on the in the control of the intraocular pressure. And this has been seen that number of patients who are actually started with monotherapy over a period of time require more than one treatment, more than one drug. So the percentage of patients which require more than two IOP lowering agents are nearly 40% by 5 years of time, and nearly 75% or more than that after 2 years of starting the glaucoma treatment. So the problem is that if you give so many vials to the patient, the compliance is going to decrease. So what are the rationales for using triple combination therapy? Till now in the market we have the combination of two drugs. But what are the rationale? It increases the efficacy because it provides additional lowering of the intraocular pressure because of the synergistic effect on lowering the intraocular pressure, which improves the adherence to treatment because it simplifies the complex regimens and patient has to put twice a day, and there is reduced exposure to the preservative. So the new combination which has hit the market is brinzolamide, bremonidine and timolol. So if you look into the individual components which are there, basically any multiple drug combination should be such that the mechanism of actions are different so that they have a additive effect on lowering the intraocular pressure. So the drug which are used here are timolol, bremonidine, brinzolamide. Timolol actually reduces the aqueous humor production, and bremonidine again, it is an alpha-2 adrenergic agonist. It reduces the aqueous production as well as it increases the outflow, and it has got the neuroprotective role also. And brinzolamide acts on the carbonyl anhydrase enzymes, and this is an inhibitor of this CA, which reduces the aqueous humor production. So these all together actually increases the efficacy of the drug and decreases the aqueous production, reduces the intraocular pressure by 25%, more than 25%. The single drops like timolol, it decreases pressure by 25%. Convenient dosing of BD dose. Brinzolamide again, convenient dose of twice a day, it reduces the pressure by 20. And brinzolamide, it reduces pressure by 20 to 25%. And if these all are combined, then the synergistic effect is able to reduce the pressure by nearly 45% as per the data given by the suppliers and the various studies. And the diagonal control of the intraocular pressure is also better as compared to the monotherapy or the dual drug combinations, and obviously less chance of preservative induced corneal toxicity. So there are clinical evidences to support the efficacy and safety of these triple drug combinations. In one of the studies which compared actually the efficacy and safety of two fixed combinations like timolol dorzolamide versus timolol dorzolamide brimonidine in a double mask multicentric study, they found that the IOP reduction was nearly 42% in the triple group as compared to nearly 29% in the two group drug, and also it was more safe and more effective. In another study, the combination actually was preferred over separate use of their component to improve the adherence and persistence with the treatment apart from the decrease in intraocular pressure, which was quite significant. And in one Indian trial which the company quotes, they have conducted in nearly 8 centers, and the end point was change in IOP from baseline at 3 months of time, and they noted that the decrease in intraocular pressure was nearly 41%, and the proportion of patients who attained intraocular pressure less than 18 millimeter at the study was nearly 87%, and there was good acceptance by the patient as well as far as tolerability is concerned. So the triple combination therapy can be an effective option in the therapeutic armamentarium for the management of patients with open angle glaucoma and ocular hypertension. So what are the benefits of this fixed dose combination which has come to the market? It improves the adherence, reduces the burden of putting so many bottles, and at the same time price also, it is cost effective because the patient don't have to pay so much for 2 or 3 vials. And obviously talking again and again about the corneal toxicity, definitely the dry eyes is a very important co-association of any treatment of the glaucoma medicines. So these patients, they do develop dry eye, but with the triple drug therapy, the chances of dry eye is less. So safety and tolerability of the triple combination has been studied, and it was found to be very safe without so much of the adverse effect, and it was well tolerated. And only 3 to 7% of the patient could discontinue it because of the treatment related side effect. So just to summarize, it increases the efficacy of glaucoma management by decreasing the intraocular pressure by nearly 41%, provides additive or synergistic effect, very much convenient for the patient, and increases the compliance, reduces exposure to preservative, and with less systemic side effect and local side effect. So this new drug can be used a very good alternative in the medical management of the glaucoma. Thank you so much.
Now I will like to call Dr. Sanjeev sir for his talk on glaucoma management beyond IOP and drugs from last session. Actually, sir's talk was left over.
A very good afternoon to all of you, and my special thanks to my big brother Dr. Ravi Ranjan, friends of Sahabad Ophthalmic Society like Amitav and Amresh, Rakesh, and many more, and a special thanks to CSC Dr. Gyan Bhaskar for giving me the opportunity. So now coming to the topic, as we all know that glaucoma is a multifactorial chronic progressive ocular neuropathy, and there is acquired loss of ganglion cells, and there is atrophy of the optic nerve head, and it leads to the permanent loss of vision. The various available treatment options like medical, laser, and surgery, and they focus on control of IOP, and it neglects the approaching the disease as a systemic manifestation and treating the patient as a whole. So this is least talked about, least understood topic. So glaucoma patient has allostatic overload indicating physiological dysregulation to chronic stress. There are external stressors like lifestyle changes, problem in the relationship, social media, negative news. It leads to irritability, depression, and anxiety. And internal stressors like poor sleep, lack of appetite, excessive exercise, and it leads to exhaustion, lack of motivation, and burnouts. So there is direct relationship between stress and IOP, as it leads to rise in the cortisol, and which in turn elevates the IOP. Stress leads to sympathetic overactivity, which in turn causes vasoconstriction, and it decreases the blood flow, and it causes tissue hypoxia also. So hence science of mind-body medicine becomes vital for glaucoma patients, and lifestyle interventions like healthy diet and meditation can be very helpful in reducing the stress and modulation of the autonomic nervous system. The word yoga has come from Sanskrit root yuj, which means to unite, to join, or yoke, and make one concentrate towards a particular task. Yoga is a set of exercises vital for health promotion, disease prevention, and rehabilitation. It primarily involves the physical postures like asana, controlled breathing, pranayam, and meditation is dhyan. Yoga can work like a double-edged sword because few positions having detrimental effects on IOP, whereas some have beneficial effects too. So IOP begins to rise upon assuming head-down position like Sirsasana. There is rise in IOP. 4 yogic postures like Adho Mukh, Swanasana position, Uttasana position, Halasana, and Viparita Karani position adversely affect the blood flow towards the optic nerve and especially rise of the intraocular pressure. So these positions should be avoided. Right nostril breathing is called the Surinari Pranayam, and left nostril breathing is called the Chandranari Pranayam, and alternate nostril breathing is called the Anulom Vilom Pranayam. These are safe and do not increase the IOP in normal subjects. So right nostril breathing increases the sympathetic overactivity, and whereas the left nostril breathing increases the parasympathetic activity and have beneficial effects on lowering the IOP. So right nostril breathing Surinari is for, it controls the left brain. This is for logic, analysis, and efficiency, and it helps in digestion, activates mind, and activates body. Whereas Chandranari Pranayam, this is for creativity, art, language, and dance and music. So it has cooling and calming effect on the body. It slows digestion, relaxes mind. Meditation refers to a family of self-regulation practices that focus on training, attention, and awareness to bring mental processes under great voluntary control. A short-term course of mindful meditation was found to reduce the IOP, reduce stress biomarkers, and positively modulate the gene expression with an improvement in quality of life in patients of glaucoma. This is associated with EEG changes and also structural changes in the brain, and it improves the cerebral oxygenation with an increase in brain-derived neurotrophic factors, suggesting a possible role of preventing the retinal ganglion cell death. And it has been suggested as an effective strategy for stress reduction caregivers, which is also a neglected aspect. They suffer a lot, actually, those who are caregivers. And technique involves low risk, low cost, and can be universally done by the glaucoma patients, even if elderly or bedridden. In this, we can see that after meditation, there is decreased cortisol and inflammatory biomarkers, improved oxygenation to the brain, and decrease in intraocular pressure, and decrease in glaucoma severity, and improvement in the quality of life of glaucoma patients, whereas elevation of stress, cortisol elevation, increase in glaucoma severity, adverse quality of life index. 365 breathing technique. So this is, in this condition, breathe in for 5 seconds and breathing out for 5 seconds. It should be done 6 times per minute, and the total duration lasting for 5 minutes. So it should be done for 365. 3 times per minute, 6 times a minute, and for 5 minutes. So it should be slow and steady, the breathing, which decreases the heart rate and relaxes muscle. So these are the yoga ocular exercises like palming. So It has a vasodilatory effect on the epicycloid veins and thus triggers circulation and outflow of the aqueous humor, which helps in proper nourishment of the ocular muscles. Blinking emboldens the blinking reflexes to become spontaneous and this is relaxation of the extraocular muscles. So these are the sideways viewing, front and sideways viewing. Diagonal viewing balances the superior rectus, inferior rectus, superior oblique, and inferior oblique, and rotational viewing restores the balance in the extraocular muscles around the eyeball and improve coordinated activity of both eyeballs and its muscles. So these are the ocular exercises. And nose tip gauging, everybody knows that this is encourages the accommodating and functioning part of the ciliary muscles. Near and distance gauging, same as the above. Now intense concentrated gauging like Trataka Kriya, it balances the nervous system, relieves nervous tension, anxiety, depression, insomnia. And acupressure point in the palm, this is between the index and middle finger. So Trataka Kriya is staring continuously at a candle flame that is placed few feet away from the eye, or staring at distant objects like sun, star, or moon, and until the buttering of the eye starts. So it leads to contraction and relaxation of ciliary muscles, leading to increased outflow of the aqueous humor. So in this picture we can see that after the yoga ocular exercise there is increased metabolic activity in the skeletal muscles, increased skeletal muscle interstitial fluid osmolality, fluid efflux from plasma to a skeletal muscle interstitium, and there is increased skeletal muscle hydrostatic pressure. There is dehydration, reduction of vitreous volume, and ultimately there is reduction of the intraocular pressure. So everybody knows 2012. This is for actually computer vision syndrome. These are the tips for practicing yoga for eyes. Practice in quiet space combined with deep breathing. Be consistent and avoid overexertion. These are the tips of maintaining good eye health, like eat a balanced diet, protect your eyes from ultraviolet rays, avoid smoking, take breaks from screens, and schedule regular eye checkups. Coming to the conclusion part, yoga practice influence eye fluid levels in both healthy and clinical populations. Thus it may be a promising adjunctive therapy for the management of IOP and prevention of condition. However, it is important to undergo proper clinical evaluation before starting a yoga therapy program for the management of disease with elevated IOP levels. So it has a multidimensional positive effect on glaucomatous retinopathy and quality of life in glaucomatous patient and serve as a polypillar glaucoma. So we have to treat the eye as well as the patient behind the eye. Thank you so much. My special thanks to Dr. Anamika, my JR. Thank you so much.
Thank you, sir, for the very informative talk. Now I will like to call Dr. Sana Parveen for the next talk. She will be presenting on a challenging case, patient female having Down syndrome with total cataract.
Good afternoon, everyone. I'm going to present a case on total cataract in a 21-year-old female with Down syndrome, a clinical challenge. Operating surgeon was Professor Dr. Amresh Kumar, Narayan Medical College. There is no conflict of interest and financial interest is also none. Introduction. This case report represents challenges faced during cataract surgery in a Down syndrome patient operated under local anesthesia rather than general anesthesia. Case report. Here I present a case of 22-year-old female who reported to our OPD with a complaint of gradual progressive painless diminution of vision since 6 months in both eyes. There was no history of redness, photophobia, floaters and flashes. There was no history of any ocular surgery or trauma. She has no history of diabetes and hypertension. She has a past history of psoriasis since 3 years for which she was on treatment with injection triamcinolone acetonide for 1 year. Patient was referred to cardiac department where she was diagnosed with adult congenital heart disease, 10 mm subaortic VSD with left to right shunt. General examination revealed she had mongoloid face, flat facial profile, flat nose with flat nasal bridge, short neck, narrow short palate with small teeth and furrowed protruding tongue. Hands are short and broad, wide gap present between first and second toes. This is the clinical photograph and it was all taken with the patient consent. Ocular examination revealed normal head posture. Vision was PL positive and PR could not be assessed. Epicanthal folds, upward slant of eyes, oblique palpebral aperture, bluish discoloration of sclera was present. Intumescent cataract was present in both eyes. The rest of the examination was essentially normal. The fundus was not visualized as it was hazy media. Intraocular pressure was 16 and 15 millimeters of mercury in the right and left eye respectively. However, ultrasound B scan revealed bilateral cataractus lens, healthy and attached retina. Biometry was done and IOL of 22 diopter and 20 diopter power were implanted in the right and left eye respectively. Anesthesia department refused to take the patient under general anesthesia, but anesthesia team and cardiologist were on standby. We took the patient for cataract surgery under local anesthesia. First right eye was operated, followed by left eye 1 week apart. Phaco aspiration technique was used and IOL was implanted. Operating the fellow eye was much more difficult as she was able to see from the fellow eye, which made her anxious. Surgery went uneventful. Conventional post-op treatment was given. Post-operative day 1 revealed clear cornea, round and normal reacting pupil with PC IOL in the capsular bag. Vision was 6/9 unaided and intraocular pressure was 16 and 17 millimeters of mercury respectively. A good fundal glow was appreciated. A subsequent visit on day 7 revealed a vision of 6/9 unaided in both eyes and intraocular pressure were 14 and 16 millimeters of mercury respectively. After 4 weeks, the vision was 6/6 unaided in both eyes. IOP was 14 and 15 respectively. This is the post-op photograph. Discussion. Down syndrome is the most common chromosomal anomaly in children with a frequency of 1:700 newborns. It occurs more often in offsprings of mother conceiving at older ages. The risk in the newborn is 1:1550 if maternal age is 15 to 29 years, 1:800 at 30 to 34 years, 1:270 at 35 to 39 years, 1:100 at 40 to 44 years, 1:50 after 45 years. 60% of these patients have ophthalmic manifestations. Brown et al. In 2015, reviewing the general anesthesia in Down syndrome children, noted that increased sensitivity to sedatives, risk of bradycardia and respiratory complications. Comparatively, in our study and studies like Mehta et al. Done in 2020 that evaluated regional anesthesia approaches in ophthalmology found that local anesthesia is safer in certain patients, avoiding the systemic risk posed by general anesthesia, especially in those with existing cardiac anomalies. Conclusion: cataract surgery under local anesthesia in adult with Down syndrome can be a safe and effective approach, offering the benefits of avoiding general anesthesia related risk. When carefully selected and counseled, patient with moderate intellectual disability can achieve excellent visual outcomes, significantly improving their functional vision and quality of life. Thank you.
Thank you. Next I will like to call Ankita Singh madam for her next talk. Actually, ma'am has to leave early for certain work. And there is an important announcement. Presenters and speakers to collect their memento from the certificate and memento from reception.
Good afternoon, everyone. Thank you, boss, for giving me this opportunity. There is no financial or conflict of interest. So we'll be discussing a case which is being managed by Innovative Management with the help of DALC lenticule, which is taken out from the host patient during the DALC surgery, and which is of no use to the patient or to the doctor, which we have used to manage it in a case of dermoid. Consent has been taken from the patient party. Limbal dermoid are choriostomas known as congenital benign tumor found in abnormal location. Despite the being benign nature, enlarging limbal dermoids may cause visual abnormalities by corneal infiltration with fat component, visual axis invasion, gradual induced astigmatism, and finally result in anisometric amblyopia. So this is a case report of 2-year-old female child, which is a normal delivery, which has been taken birth by normal delivery, normal gestational age, and no intra or post-operative complication, and was brought by her parents with chief complaint of white mass in right eye since birth, which was progressive in nature. Her parents claimed that there was no family history in the family. So right eye examination revealed a white solid mass, ovoid mass over the inferior lateral limbus covering up to the pupillary border. Dermoid size was approximately 7 by 7 mm. Partial keratinization with hair follicle was noted on the surface of dermoid, and there was no associated regional or systemic abnormalities in the patient. So visual acuity taken which was right eye 660 and left eye 69. IOP was digitally normal, left eye examination was normal, fundus both eye was normal. So patient was planned for dermoid excision with post-DALC lenticule to be used in place of lamellar corneal grafting with the help of fibrin glue under general anesthesia. So this is the surgical technique which has been used. The size of the dermoid was noted, and conjunctiva was resected. Trephine was used for partial grooving, then partial scleral thickness dermoid was removed along with the corneal involvement. With the help of the crescent, the scleral groove was made, and approximately from the depth of the sclera to the cornea, the dermoid was excised. As we can see in this video, after the excision of the dermoid, the lenticule which was preserved in Kesol media in our eye bank, that was used, and that was excised up to approximated on the basis of the clinical judgment. It was excised up to the approximate depth, and then this lenticule was placed over the excised part, and it was apposed on the host with the help of the glue, and the BCL was placed at the end of the surgery. So post-operative medication were topical antibiotics, steroids, cycloplegic, lubricant, ointment lubricant, systemic steroid on tapering dose, systemic antibiotic with painkiller. On first month post-operative, patient was taken under EUA. As in the first picture, we can see the fluorescent staining was done to rule out any ocular surface or disproportionate approximation of the host and graft junction. There was a slight irregularity. Otherwise, the all graft and host junction were well opposed and taken up to the patient's bed. On retinoscopy, the patient retinoscopy in the vertical was +4, horizontal was +5, giving a very minimal residual refraction in post-operative period, and the patient vision was 6/9 partial. Now coming to discussion, corneal dermoid can lead to astigmatism, amblyopia, even monoocular blindness if they involve the visual axis or cover the pupil. A commonly used surgical approach is dermoid excision combined with lamellar keratoplasty. It adopts the concept of split cornea transplantation to cover the overcome global burden of corneal tissue shortage, and the cost and waiting time for corneal transplantation could be significantly reduced. Anterior corneal button prepared during excision of host tissue in dial surgery showed great success in treating grade 2 dermoid from transplantation. So to conclude, this is a case report not only demonstrate a successful surgical technique, but also shows a method with great potential for reducing the global crisis of corneal tissue shortage with great surgical outcome. So novelty of this surgery or the case is lenticule preservation and reuse of clinical reuse for the tissue for clinical use, and it was the best uses out of waste. This is the pre and post operative picture of the same patient. Thank you.
That was really excellent, Dr. Ankita. Can you tell us what was the source of that dark lenticule and what kind of case it was from which it was extracted actually in the first place?
It was a case of keratoconus patient of 18-year-old patient, and the consent of the patient was also taken that we are going to use your cornea which is of not your any use, and it will be used in the a child which a patient can regain vision after the surgery.
That's really very innovative. Thank you.
Thank you.
Next, I would like to call Dr. Paras Kharbanda, PGT, Narayan Medical College, for presentation on sunflower cataract.
Thank you for giving me the opportunity. My name is Dr. Paras Kharbanda, first year resident in MCS Sasaram. I will be presenting a case on sunflower cataract. There is no conflict of interest or no financial gains. 28-year-old male from Aurangabad who is a daily wage worker presented with diminution of vision in both eye, right eye more than left eye for past 8 months. Patient was apparently well 8 months back when he developed diminution of vision in both eye. The symptoms were insidious in onset and gradually worsened over past 8 months. His complaints were predominantly associated with glare. There was no history of ocular pain, redness, photophobia, colored halos. There is no history of trauma or systemic manifestation, just as headache, such as headache, dizziness, tremors, altered mood, or hepatic dysfunction. There is no significant past history, medical history, or surgical history. My patient was having a mixed diet, sleep and appetite were normal, regular bowel and bladder habits, non-smoker, non-alcoholic. No family history was non-contributory and with no known genetic disorders or similar complaints in a first-degree relatives. Patient was moderately built and well-nourished, conscious and well-oriented to time, place and person. No pallor, clubbing, icterus, cyanosis, lymphadenopathy or edema seen. Vitals were normal. On systemic examination, no abnormal finding was found. Normal facial symmetry was there and normal head posture was there. Ocular examination, visual acuity of distance in the right eye was 624, which improved on pinhole and improved to 618, and in the left eye it was 612, which improved to 6/9. Near vision by N12 in the right eye and N6 in the left eye. Lids and conjunctiva were normal of both the eyes. Cornea was transparent with no vascularity. Greenish brown pigment deposition at level of Descemet membrane, which was present at the periphery, suggestive of KF ring. Similar finding was found in the left eye. Anterior chamber and iris were normal in both the eyes. Pupil was normal in size, shape and normally reactive to light in both the eyes. Lens had a golden brown anterior subcapsular opacity in the central region which with stellate pattern radiating from center resembling sunflower petals, suggestive of sunflower cataract. In the left eye, similar findings were found, but less pronounced pattern. Fundus examination done by slit lamp. Media was slightly hazy in the right eye, but normal in the left eye. Disc was normal with CD ratio 0.3. FR was present. Macula, vessels, and periphery were normal. Extraocular movement in both the eyes were normal. Gaze was orthophoric in both the eyes. Rhoplast was absent in both the eyes. Syringing was patent in both the eyes. IOP done by GAT at 10:30 am was 16 and 14 mm of Hg respectively in right eye and left eye. This was the clinical picture of the patient in the right eye and left eye. A young male 28-year-old came to ophthalmology OPD with complaints of diminution of vision in both eye for past 8 months with progressive decrease in vision associated with glare. On examination, right eye showed KF ring along with characteristic sunflower cataract in the central region with stellate opacity radiating from the center, resembling the pattern of sunflower petals. Fundus details were normal. Left eye showed KF ring with cataractous changes of similar pattern but less pronounced. Fundus findings were normal. IOP was 16 and 14 respectively. Presence of KF ring along with golden brown anterior subcapsular opacity is suggestive of sunflower cataract. The presence of this pattern is in absence of any trauma or other obvious ocular pathology suggests the possibility of systemic etiology, most probably Wilson disease. Differential diagnosis can be nuclear cataract, but this is less likely because of the specific pattern of the cataract found. Traumatic cataract, in absence of any trauma, it is also less likely. Congenital cataract, because of the age of onset, it is less likely. Metabolic or genetic cataract possibilities include cataracts associated with metabolic disease, especially Wilson disease. Serum ceruloplasmin level, we can investigate. Serum copper levels, 24-hour urinary copper excretion test, liver biopsy. is the gold standard slit lamp photography and high definition documentation of cataract for further analysis. Genetic testing for ATP7B, LFTs, neuroimaging like MRI and CT, psychiatric assessment can be done. Ophthalmic management, cataract surgery indicated if the visual acuity continues to decline or significantly affects the quality of life. Lens extraction with IOL implantation may improve the vision. Pre-operative assessment of systemic health is required. Wilson disease is a rare genetic disorder which can involve multiple systems. So for other systems we can require copper chelation therapy, initiation of agents such as penicillamine and triantine, which are copper chelators that can reduce the copper accumulation. Zinc can block the copper absorption from the GIT. Liver function monitoring is done regularly. Multidisciplinary follow-up or hepatology consultation, because later in life it can lead to liver failure. Neurological consultation and psychiatric assessments are also necessary. Thank you.
Nice, very nice case. What would be a plan of action in your patient? Do you want to do something for your patient right now?
Yes, ma'am, we did the surgery. We did the cataract surgery.
And what is the post-operative outcome? And what lens did you choose? कौन सा lens डाला?
Posterior chamber IOL.
Which lens? Means I want to know what make of lens or what type of lens did you choose for this? Because this is a very young patient, long term he has to remain, and then one eye will be, probably you did in one eye only, no? Cataract surgery. So one eye would be accommodating, the other one, which lens would you choose? कौन सा डाला? मतलब what was your mentor's obviously choice? Alcon का monofocal डाला? Okay. Thank you.
Thank you, Paras, for such a nice presentation. Now I will like to call Dr. Susan for next presentation on dislocated IOL.
Thank you for the opportunity. I will like to thank you for the opportunity. Good evening, good afternoon to all. I, Dr. Sushant Kumar, I'm going to present the case of the dislocated IOL of the both eye. Personal information. My patient Jatu Das, age 74-year male, resident of Konch district Rohtas, and he is a farmer by occupation. The chief complaint was the diminution of the vision in both eyes since 1 month and a glare in both eyes since 1 month. History of the presenting illness. My patient was apparently well 1 month back when he developed blurring of the vision in both eyes, which was sudden in onset, progressive in nature and painless. He also complained of the glare in both eyes since 1 month. There was no history of diplopia, floaters or flashes. Past history, the patient was undergone cataract extraction with PCIOL implantation in both eyes 10 years ago. At around 1 month back, he suffered blunt ocular trauma after an accidental fall from his head. No history of diabetes, hypertension and other cardiac illness. The family history was not significant. Personal history was patient was of the mixed diet, non-alcoholic, non-smoker. Bladder, bowel and the sleep appetite were normal. General examination. Patient is moderately built and nourished. Patient is well oriented to the time, place and person. There was no pallor, icterus, cyanosis, clubbing or pedal edema. The vitals were in the normal range. Systemic examination, respiratory system was bilaterally normal and the CVS, CNS and the per abdo were normal. Ocular examination. Visual acuity was 360 with no improvement with pinhole in right eye, and 160 with no improvement with pinhole in left eye. Adnexa, conjunctiva and cornea are in normal range, and anterior chamber were normal in depth and content in both eye. Iris is normal in current and pattern in both eye. Pupil was normal in shape, size and normal reaction to the light in the both eye, and the lens was found to be dislocated from its normal position. IOP was noted to be 15 and 13 in right eye and left eye respectively. On fundus examination with 90D lens and 20D lens, the disc appeared to be normal with CDR of 0.3 and 0.4 in right eye and left eye respectively. Rest of the fundus appeared to be normal. The investigation was suggested for BE scan, routine blood examination for blood and operative tests, blood pressure and the IOP measurement. This was the BE scan report advice showing the dislocation of the PCIOL in the vitreous in both the eye. The clinical summary. Mr. Jatu Das, a 74-year-old man, came with the complaint of sudden, painless and progressive diminution of the vision in both the eye for 1 month and glare in both eyes since 1 month. He has undergone cataract extraction with PCIOL implantation in both the eye 10 years ago. He has sustained a blood ocular trauma 1 month back. On clinical examination and B scan report, both the eye PCIOL were found to be dislocated posteriorly in the vitreous cavity. The provisional diagnosis was on the behalf of the history, clinical examination and the B scan report. This is the case of a posterior dislocation of the PCIOL in the both eye. Patient was advised for the removal of the dislocated PCIOL with IOL exchange with transscleral suture fixation under the guidance of the vitreoretinal surgeon. This was the post-operative image with suture for the transscleral suture fixation. The plan of the management of the dislocated IOL, reviewing the operating notes from the previous cataract surgery to determine if there were any complications such as retinal detachment, cystoid macular edema, weak jonules or the posterior capsular bag rupture, elevated IOP pupillary block or angle closure from the IOL dislocation should be assessed to determine the urgency of the surgery. B scan ultrasonography to detect the degree of the IOL dislocation. The management is generally divided into 3 parts. First one is the observation, then the repositioning of the IOL, and third one is the IOL exchange. In observation, dislocation is mild, asymptomatic and non-progressive. It can be observed without surgical intervention. Patients with pseudo-phacodonesis and without inferior dislocation are usually asymptomatic and tend to be the good candidates for observation. Observation may also be appropriate if the patient has systemic comorbidities such as uncontrolled diabetes, Stickler syndrome, SLE, and which make the surgery unadvisable. Repositioning of the IOL. The decision of reposition will depend on the individual circumstance. For decentered lens, where the bag and jonules are intact and the lens in the bag, the simplest approach is often to perform a in the bag IOL reposition. An intact 3-piece lens can often be repositioned through the sulcus placement, in which the iris suture or the scleral fixation. In 1-piece lens usually need to be exchanged unless it is in the capsular bag and the bag can be preserved. However, new technique is using an intraocular punch to put a hole in the optics haptics junction in 1-piece lens may also allow the scleral fixation of the 1-piece IOL in the sclera without the need of the IOL exchange. These techniques allow the patient to retain the multifocal lens. Surgical correction and technique. The choice of the lens and the best fixation approach depend on the anatomy of the eye of the patient. The patient with corneal decompensation or the glaucoma and anterior chamber IOL should be avoided. In patient with the iridogenesis and the iris fixation IOL is contraindicated, and the posteriorly placed scleral fixated IOL may be considered to prevent complication of the UHG and CME. Thank you.
Excellent case. I think the bilateral dislocations of the IOL out of a single trauma are rarely reported. I think you should report your case. It is worthwhile to report this case. And another thing is, what was the type of IOL that was dislocated?
Transscleral fixation IOL was used. Actually, ma'am, this case was not managed at our location.
okay, it was banished at BHU. So BHU people are doing sclera fixation and they're having retina services to take out the IOL now. Okay, that's very nice. Heartening to note. Okay, fine. Thank you.
Thank you, Suzanne. Now I would like to call Dr. Shauravi for the next presentation on fungal corneal ulcer.
Good afternoon, respected judges, teachers, my colleagues, seniors and juniors. I am honored to present a case report on fungal corneal ulcer following ocular trauma with vegetative matter. A case report. It's a case report because this case is a bit unique with pain which is not generally present in a fungal corneal ulcer. Introduction. Infective keratitis is a major cause of corneal blindness in developing countries. Fungal keratitis is common in rural India due to agricultural trauma. Typical features are dry-looking, feathery-edged ulcers, satellite lesions. Early diagnosis and management critical to avoid complications. Case demonstrates classic fungal keratitis managed as per All India Ophthalmic Society guidelines. Patient profile: name Mr. Ram Narayan, age gender 52 years, male, occupation paddy field worker, residence Kaimur Bhavua, Bihar. Chief complaints: diminution of vision in left eye for 2 weeks, severe pain in left eye for 2 weeks. Trauma to left eye with straw 3 weeks ago. 1 week later, deep pricking pain, redness, photophobia, discharge which was watery in nature. Gradual diminution of vision of left eye for 2 weeks which was progressive in nature. No history of contact lens use, headache, halos or diplopia. Past and drug history: no history of ocular or systemic disease or surgery. No history of diabetes, hypertension, TB or asthma. On topical moxifloxacin dexamethasone for 1 week taken from pharmacy. Personal and family history: diet mixed, substance use, smoker and tobacco chewer. Sleep disturbed due to pain in the left eye. Appetite is normal. Bowel and bladder habit is normal, and family history: no similar ocular complaints. General and systemic examination: general, moderately built, nourished, afebrile and vital stable. Respiratory system clear, CVS S1, S2 no murmurs, CNS normal, abdomen soft and non-tender. On ocular examination we see left eye which have the ulcer, visual acuity is hand movement positive, lid and agnexa, mild lid edema, conjunctiva mild conjunctival congestion, cornea dry looking feathery ulcer, satellite lesions, positive fluorescent stain, 6 into 4 mm square, mild circumciliary congestion, ACVC plus 2 cells and flare, pupil round and sluggish in reaction, lens non-visualized, fundus couldn't be visualized, orbit is normal, lacrimal syringing is patterned, Doppler's is negative, puncta visible everted, IOP is taken at 11 am by non-contact tonometry 10 mm Hg, corneal sensation was present and extraocular movement was within normal limit. This is the picture showing the corneal ulcer with fluorescent stain in the left eye. Investigation: KOH mount positive for fungal filaments, gram stain negative, SDA Severon dextrose agar, culture is Fusarium species, RBS, CBC, ESR normal. Diagnosis: fungal corneal ulcer, left eye, etiology Fusarium, cause trauma with a straw. Bacterial keratitis: differential diagnosis: bacterial keratitis, viral keratitis, acanthamoeba keratitis, autoimmune peripheral ulcerative keratitis, Morell's ulcer, neutrophic keratitis, medication, toxin-induced keratitis. Management: natamycin 5% hourly is a drug of choice, moxifloxacin 0.5% 4 times, atropine 1% 3 times, oral keratoconazole 200 mg 2 times, lubricants, avoid steroids and daily monitoring. Clinical course: day 3 pain is reduced, day 7 ulcer size is reduced, day 14 epithelialization forming scar, vision improved to counting figure in 1 meter. Discussion: fungal ulcer needs early suspicion, Fusarium is most common post-vegetative trauma, steroid use delays the healing, natamycin 5% is a drug of choice, All India Ophthalmic Society recommends early scrapping and targeted therapy. Prognosis and follow-up: vision improved from hand movement to counting finger in 1 meter, no perforation, possible optical keratoplasty later, and monthly follow-up advised. Learning points: suspect fungal keratitis post-trauma, avoid steroids without fungal ruling out, early scrapping and antifungal initiation, follow AIOS management protocols. References: AIOS guidelines, infective keratitis, Thomas, Gopinathan and Prajna. Thank you.
Nice case, but how it was different from a regular fungal ulcer that you see? You said that this course was different. So it healed in 24 days approximately, and no special drugs or interventions were needed. So how it was different from a usual course?
Sir, ma'am, can you please repeat the question? Can you please repeat the question? Ma'am, can you please repeat the question?
Yeah, sure. So how was, you said that at the beginning that this case, in course of this case is different from a usual fungal ulcer. So how different was it and what was different about this?
Ma'am, this case presented the patient came with severe pain, which is generally not seen in a fungal ulcer case. It's maximum times seen in viral case, or max to max is seen in bacterial case. So in fungal case, this patient presented with a severe pain, so I thought it is a case, it should be case report.
Okay, fine. But I think this clinical examination is very important, very, very typical of a fungal ulcer. Okay. Thank you.
Thank you, ma'am.
Thank you, Dr. Sarvi. Now I will like to call Dr. Ashish for his next presentation.
Good afternoon, everyone. I'll be presenting on corneal ulcer masking the underlying disease. It's a very interesting case, and I myself have learnt a lot from this case. I'll take you down through the events which has happened in this case and what was the final diagnosis. So this 65-year-old lady came with complaints of left eye redness, pain, watering since 2 months. Right eye, there was a progressive diminution of vision since 3 years. She was previously treated with topical antibiotics, cycloplexix, and there was no past history of any systemic disease, not on any oral medication. An examination of oral mucosa and skin revealed no erythematous erosive lesions or blisters. So this was the right eye. The vision was, PL was present, total LACD with semleferon, whereas in the left eye, there is a counting finger at 2 meters, and there was a corneal ulcer with pseudoteresium and a 360-degree vascularization. I thought it's a case of corneal ulcer, and we did a basic workup, and it started on fortified ceftazidime, natamycin, and homide. I was not sure what kind of, the presentation was very unusual, so I started both. Then 3 days later, this patient came with a worsened corneal ulcer, and there was a trace hypopyon, and patient was added with, we added voriconazole and moxifloxacin also. On 10th day, corneal ulcer worsened. She was unable to open the eye. That is the time when I noted upper lid subconjunctival fibrosis and lower lid shortening, pharyngeal shortening. I thought it could be a case of ocular secretorial pemphigoid because of the clue was in the other eye, right eye, which I showed here. And she was planned for conjunctival biopsy immediately on the same day, and we sent for DIF and histopathology. We took 2 samples of conjunctiva and was sent to Delhi, and we did all the blood tests, and rheumatology opinion was sought. I sent the patient to rheumatologist, but somehow patient didn't go, and we started this patient on oral Vicelon and mycophenolate mofetil, and continued antimicrobials. On 17th day, this patient came, and the report came negative for DIF, and histopathology sample somehow was lost while on the way. So this time patient has improved, corneal ulcer was resolving, hypopyon disappeared, and we continued the same medication. And so I sent the patient last time, but patient showed rheumatologist but never came to me. She came on like 5th week, and rheumatologist also added methotrexate to this all this already immunosuppressants. I actually wanted this patient to start with cyclophosphamide, but somehow the rheumatologist didn't start. This patient was prescribed 3 immunosuppressant, but this patient, because of the economic condition of the patient took medicine only for 1 week, and she was coming after 3 weeks of follow-up. So she was not on a steroid, not on methotrexate, and not on mycophenolate. Patient condition worsened. It was about to perforate. There was a descemetous heel, So I planned for amniotic membrane. Since amniotic membrane was also not available, so I said I'll get it in 48 hours and we'll plan your surgery in 48 hours. But again, patient was lost and she came after a week. Still that same amniotic membrane we could put. And now I knew that patient is not able to understand the disease course. It's an end stage disease. She has already lost the right eye. She is going to lose the left eye also. So I was now behind the patient rather than patient was not following me. So I thought, so I started supporting the patient and we started positively counseling the patient, somehow made her understand this is a serious disease. So this patient underwent multi-layered AMT and after 2 weeks, this is the last follow-up which I just saw recently, and amniotic membrane is almost melted within 2 weeks. Patient is still on Vislon, mycophenolate and methotrexate. She is doing much better. The vascularization has decreased. There is no impending perforation. Ulcer has almost healed, and there is no infection also. So this was a case of ocular secretaceal pemphigoid. Like I said, the right eye has the clue. There is almost no phonesis with a total semlepharon. Although the recommendations are you should have a positive histopathology in these cases of OCP, but clinical suspicion is the most important. And these are some of the differential diagnoses. So basically you have to rule out a couple of secretaceal disease like SJS in these cases or severe allergy. And so the OCP is a subset of systemic autoimmune disease, mucous membrane pemphigoid, which extensively involves all the mucosal surfaces like oral cavity, larynx, pharynx, esophagus, nasal cavity, genitalia. It's a type 2 immune reaction, and eye may be the first or the only tissue to be affected in almost like 32 to 48% of the cases. Incidence is very rare. It's 0.8 to 2 per million. Average age at onset is 65. It's a bilateral asymmetrical disease, and it's a progressive disease. Involvement of the medial canthus with loss of caruncle and praeca semilaris is one of the initial clinical signs. So there are 5 pearls which I would like to discuss. First, you have to see whether it's a disease is a unilateral or bilateral. Bilateral, most likely is a case of OCP. There is any other mucus involved or skin involved, so that you can differentiate between SJS. Is there any systemic disease, like a patient has a graft versus host disease or a paraneoplastic syndrome? Is there any meibomitis or a rosacea kind of picture? Could be due to SJS. Or is there any use of topical medication like anti-glaucoma medication which can cause again cicatrizing conjunctivitis, mostly with the AGM, and also take a history of viral conjunctivitis or a history of allergy in these patients. So the management is step ladder pattern. In mild to moderate disease, generally methotrexate and I'll just finish. Methotrexate or mycophenolate. In severe disease, we tend to start with cyclophosphamide, injection IV cyclophosphamide along with the oral steroid, oral or intravenous steroids. Cyclophosphamide, we have to understand there is a limited amount of cyclophosphamide these patients can receive because it's a very the profile of there's a lot of side effect with cyclophosphamide. So 8 to 9 doses is the maximum. So you have to judiciously use this medication. If the disease is refractory or a very severe, not responding to cyclophosphamide or steroid, you have to start rituximab or IVIG. And lifelong monitoring is important for these patients because the relapse is very common. It's almost in 1/3 of the patient. So in conclusion, MMP is one of the most common cause of cicatrizing conjunctivitis with ocular involvement in 70 to 75% cases. Cornea keratitis is seen in 1/4 of the cases. And one must have a high index of suspicion in the evaluation of chronic conjunctivitis to prevent blinding complication as a result of MMP. The mean diagnostic delay for diagnosing OCP is 2.5 years. So you can understand how many cases we are all missing. And sometimes in one of the studies, it is even 10 years. So very important to know about this disease. And also at the same time, if the patients actually require an ocular surface disease specialist. So either we should treat or we should refer at the same time to a person who can handle these patients. So for me, I've been reading about OCP for a very long time and have seen also a couple of cases, referred cases. But this was the first case which I've actually seen of end stage pemphigoid which presented to me, and somehow I cannot do much for this patient because it's an end stage disease. But I think I'll be able to salvage the globe, or maybe if patient responds to these medication, we can give scleral lenses later and give some visual rehabilitation to this patient. Thank you so much.
I think great learning points from this case and excellently presented too. Thank you, Dr. Ashish.
Thank you.
Hello. Now I will like to call Dr. Mayank Goyal for the next presentation. Dr. Mayank Goyal.
Okay. Good afternoon, everyone. My name is Dr. Mayank, and I'll be presenting a fungal corneal ulcer which came to our OPD. The personal details: name of the patient was Jaimurthy Devi, age 79-year-old female, religion Hindu, and occupation homemaker. The chief complaint was pain and watering in left eye since 2 months, diminution of vision in left eye since 1 month. History of presenting illness: the patient was apparently asymptomatic 2 months back when she had injury to the left eye with a tree branch. She developed pain which was sudden in onset and pricking nature, followed by watering. She then developed diminution of vision 1 month back, which was insidious in onset and gradually progressed to the present degree in the left eye. It was also associated with redness. Patient developed intolerance to bright light in left eye. There was no history of colored halos, diurnal variation of symptoms. There is no history of glasses and use of any contact lens. Now, past history: there is no history of similar complaints in the past. There is no history of diabetes, hypertension, bronchial asthma, and TB. No history of any ocular or systemic surgeries, and the usage of any medications. Now, drug history: patient is not on any topical or systemic medications. Personal history: patient is on a mixed diet, non-smoker, non-alcoholic, with disturbed sleep due to pain. Patient's appetite is normal with regular bladder and bowel habits. Family history: no history of any similar complaints in the other family members. General examination: first of all, the physical examination. Patient is moderately built and nourished. Patient is conscious, cooperative, and well oriented to time, place, and person. Vitals: the temperature, she is afebrile. Pulse rate was 76 beats per minute on a radial pulse. Respiratory rate was 18 cycles per minute. Blood pressure was 130 by 86 millimeters of mercury. In left arm, brachial blood pressure, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or peripheral edema noted. Systemic examination: respiratory system, bilateral normal vesicular breath sounds heard, no added sounds. CVS, S1 and S2 heard, no murmurs. CNS was normal. Per abdomen was soft and non-tender on palpation. Now, coming to the ocular examination, in a right eye, the visual acuity was 6 by 18, improved to 6 by 9 with pinhole. Left eye, it was PL positive. Lids were normal in both of the eyes. Conjunctiva was normal in right eye, and there was presence of circumciliary congestion with nasal pterygium in left eye. Cornea, it was clear, smooth with normal sensation. And left eye, one central lesion of 3 into 2 mm and another peripheral lesion of 3 into 1 mm with positive fluorescent stain with few corneal infiltrates and satellite lesions were present. Anterior chamber, normal in depth and content, and left eye, immobile hypopyon of 1 mm was present. Iris was normal in color and pattern, and mild inflammation was noted in left eye. This was a picture of the fungal corneal ulcer. Now, coming to pupil, in right eye, normal in shape and size, direct and consensual reflexes were present. Left eye, it was not like it can't be assessed. Lens, transparency, color, under iris shadow. Right eye, it was cataractous, grayish in color, and the iris shadow was present. Left eye, it cannot be assessed. Fundus examination, slit lamp examination by 90D lens. Media was clear, optic disc was normal, circular, pink, and well-defined margins was present. CDR ratio was 0.3 to 1. Vessels were normal, and macula foveal reflex was present. Left eye, again, it was not assessed. Peripheral retina with indirect ophthalmoscope. Right eye was normal, and left eye was not assessed. orbit, normal in both of the eyes. Lacrimal syringing was done, which was patent in both of the eyes. Roplas was tested, which was negative, and puncta were visible and everted in both of the eyes. Intraocular pressure recorded at 1:50 p.m. on 13th May 2025 by applanation tonometer. It was 14 millimeters of mercury in right eye, and left eye it was not assessed. Now, the investigations which were supposed to be done and was advised was blood sugar, hemoglobin, total leukocyte count, differential leukocyte count, and erythrocyte sedimentation rate, complete urine and stool examination. Microbiological investigations of corneal scrapings should be done. First of all, gram staining for identification of the organisms, specifically fungal and the bacterial ones. Also 10% KOH wet preparation for the identification of fungal hyphae. And now I would like to summarize my case. A case of 79-year-old female with history of vegetative matter injury to the left eye 2 months ago, presenting with complaints of pain, watering, and diminution of vision in the same eye. On examination of left eye, circumciliary congestion with nasal pterygium along with central lesion of 3 into 2 mm, another peripheral lesion of 3 into 1 mm with positive fluorescent stain was present, with few corneal infiltrates and satellite lesions were noted, with the presence of immobile hypopyon of 1 mm in the anterior chamber. The right eye showed immature senile cataract. On investigation with 10% KOH preparation of corneal scrapings of the left eye, it revealed fungal hyphae. Provisional diagnosis was made. It was fungal corneal ulcer and nasal pterygium in the left eye with immature senile cataract in right eye. Treatment was planned for the next 7 days. We started the treatment with natamycin eye drop, left eye 1 hourly, moxifloxacin eye drop, left eye 6 times in a day, home atropine eye drop, left eye thrice daily, brimonidine eye drop, left eye thrice, and tablet fluconazole 200 milligram BD, and tablet ranitidine 150 BD, and paracetamol 650 as needed. And we called the patient for review after 1 week. The differential diagnosis can be exposure keratitis, bacterial corneal ulcer, viral corneal ulcer, iridocyclitis, and endophthalmitis. Thank you.
What was the reason for the patient developing a fungal corneal ulcer? Was it trauma or something?
Trauma to the left eye with vegetative matter.
Okay.
She was working. She went outside and a tree pricked.
A few things. I don't think you can do actually an applanation tonometry in a fungal corneal ulcer. It should not be done probably. And the other thing is that when you are confirmed and sure that it's a fungal corneal ulcer, you've confirmed that it's not a mixed infection. It's not very prudent to start antibacterial with an antifungal right away. So I think you should confirm that before going, okay? Otherwise, well-presented case. Thank you.
Thank you.
And there's some other points to be made, I think, for posting.
Yes, sir. Usually we find fungal corneal ulcer to be immobile because of the hyphae present, and the bacterial corneal ulcer is mobile. And
fungal infection, hypopyon is not mobile. Why?
because of the attachments present.
We will take questions in last. Actually, sir, we are having shortage of time. We are getting late. That's why we are trying to finish early. May I call? Thank you.
Thank you, sir.
Because of hypopyon is hyphae, so it is not mobile.
Now I would like to call Dr. Pragya for the next presentation. Senior Resident IGIMS.
Good evening all. I'll be speaking on a case of sudden blackout. So a 9-year male walks into my OPD with sudden diminution of vision in both eyes since 1.5 months, which was associated with headache and diplopia. History of presenting illness. Elsewhere he was diagnosed as a case of retrobulbar neuritis for sudden onset of diminution of vision and squint 1.5 months ago. As per the patient and the attender, the squint became better with time. There was no associated systemic illness family and personal history was not significant. So best corrected visual acuity in right eye was 3/60 and left eye was 1/60 for distance, and for near it was N18. Auto refractometer showed a variable reflex. Dry eye retinoscopy also showed a variable reflex. The color vision done using Ishihara chart was, he was able to read one plate out of 21, but with red filter he was able to identify the other 21 plates. And the dynamic retinoscopy showed a lead of accommodation. On Hirschberg, he was ortho. Cover test for distance and near showed small isophoria, which was 10 PD base out on prism bar cover test. Stereopsis was beyond 400 seconds of arc. There was diplopia. Saccades and cranial nerve examination were within normal limits. The extraocular movement were full and free in all gazes. During this 1.5 months, he underwent all investigations: VP, MRI brain and orbit, NMO, MOG, ANA, everything was normal. The OCT RNFL for this age group is not available in the machines, but clinically to me it was near normal. So on the basis of my initial examination, I had planned cycloplegic refraction for the boy with atropine 1%, which showed minimal hyperopia in both the eyes. And his glass power was 1.25 in right eye and left eye plus 1.75. So I came to the conclusion this was a patient of spasm of accommodation rather being a case of retrobulbar neuritis. So I prescribed him glasses. But after 2 weeks, both the parent and the boy came. They said, I can see clear for near, but for distance, but for near it is blur. So again, I had to reassess the patient again. This time he had a small left convergent squint. On cover test, right eye was dominant eye, and there was a small left convergent skin freely alternating. For distance, he has a ET of 18 PD, and for near it was 35 PD base out. With near PBCT with +3 was 15 PD base out. So clearly the AC by A ratio was high. So now to my diagnosis, I added it as a case of spasm of accommodation with acute onset comitant esotropia. To relieve the spasm, I prescribed him atropine 2% twice daily for 2 months, and this time I have given executive bifocals so that the near blur can be taken care. After 4 weeks follow-up from baseline, his BCVA for distance is 6.6 and for near it is N6. Hirschberg was ortho. For he had a small esophoria for near on cover test, and on measurement it was 8 PD for distance and near it is 10 PD. As in this video also you can notice a small flick in right eye. With 10 PD with 10 PD prism cover test, he is almost ortho. There is no retractile movement now. So coming to the discussion, I came across a similar case reported by my alma mater by Hussaindeen and Sumita ma'am, which also reported as a acute adult onset comitant esotropia associated with accommodative spasm. So accommodative spasm, also known as pseudomyopia, spasm of near reflex, accommodative excess, hyperaccommodation or ciliary spasm. When it is combined with pupillary meiosis or excessive convergence, it is termed as spasm of near, the prevalence being 6.4% to 10.8%. It is due to overstimulation of parasympathetic nervous system. It can be of two types. Firstly, constant accommodative tension during near work elevates ciliary muscle tone, common in young hyperopes and presbyopes, and the other one is the pathological due to its severity and duration. Signs and symptoms are sudden onset of blurred vision, apparent myopic refractive error, that is the pseudomyopia and variable refraction, diplopia. There can be limited ocular motility, photophobia, which disappears with cycloplegics. So accommodative response, it happens because there is excessive response to accommodative stimulus. Etiology can be functional or psychogenic. Neurological association needs to be ruled out because it can happen along with trauma, Arnold Chiari malformation, 6 nerve palsy also. What are the treatment options? Cycloplegic agents, refractive correction, near eye to be prescribed to deal with cycloplegic blurring for near vision. Constant follow-up is required. Vision therapy in the form of accommodative facilitative exercises using plus and minus lens, and stretch management in the form of psychological counseling. So my takeaway pearls are accommodative spasm is rare, but it do occur. Never hesitate to reassess the patient, and it may need a tailored approach. These are my references. Thank you for patient listening.
And that was a really excellent, and we should watch out nowadays for increased screen time in younger patients who have report to us, and that is very important history to take. The other very important history in bilateral, these variable refraction cases, is the ingestion of topiramate. Many people have got migraine and are just prescribed topiramate by our neurology friends or our ENT friends, and they land up into spasm of accommodation. In our clinic also, in our retina clinic at AIIMS, we recently had one case like that, and very, very interesting. Thank you.
Thank you.
Thank you, Dr. Pragya. I would like to call Dr. Rajiv for the next presentation. Is he present? Dr. Rajiv? Okay. Dr. Neha Gupta can present a case report on ocular vitriolage.
Good evening, everyone. Myself, Dr. Neha, JR1 RAO, presenting a case report on ocular vitriolage. There is no financial interest, no conflict of interest. Ocular vitriolage, a true ophthalmic emergency. Vitriolage acid attack is a form of violent assault involving deliberate throwing of chronic substances with an intent to disfigure, injure, or kill the victim. The face and eyes are the primary target, making ocular involvement a major concern. Global incidence, and an estimated 1500 to 2000 acid attack occur annually worldwide. India report approximately 200 to 300 cases per year, although the true incidence may be higher due to social stigma and non-reporting. However, as the head is often targeted, victims usually have less than 20% of the total body surface burned, and so survival is usual. With 8.1% mortality in one Iranian study, and a British study reported that only 2% of the cases had life-threatening injuries. 45-year-old male patient from Darbhanga, Bihar visited RI emergency with chief complaint of pain, redness, burning sensation, diminution of vision, photophobia, and inability to open both eyes. Date of incidence was 21st of April 2025, and presentation time was 1 day after the incidence, and mechanism was intentional acid attack by some known. History of presenting illness: patient was presented to emergency department IGMS with a superficial burn involving face, eyes, neck, and chest after an acid attack. An instant burst of acid that splashed all over him occurred. Primary treatment at DMC Darbhanga on the same day was taken, where saline irrigation was done and topical medication given. Then he came to emergency department IGMS on the next day. Primary treatment for superficial burn involving skin was given, and ophthalmologist opinion sought. On general examination, patient was conscious, oriented, alert, with time, place, and person. And vitals were with pulse 84 beat, BP was 136/90, and temperature was 99.5 Fahrenheit, and patient was of average build and well nourished. Superficial chemical burn noted all over face, neck, chest, and arm. On ocular examination, right eye visual acuity was in both eyes. Visual acuity was face count at 1 meter. Digital IP could not be accessed. Adnexa and eyelid superficial burn or lid were present, tensed and incomplete opening. Extraocular movement were free and full and free in all gazes. Conjunctiva couldn't be completely visualized and was congested, chemosed, and conjunctival staining present. Cornea was stain negative, and stromal edema present. Descemet membrane folds were present. pH of ocular surface was 5.5 in both eyes. Pupil were mid-dilated pharmacologically, and anterior segment details not clear. Fundus couldn't be visualized. Treatment course: we advise admission, but since there was an unavailability of burn ward in IGMS, we referred the patient to PMCS to get admitted in burn ward and advise follow-up. Patient insisted with daily follow-up with us. On day 1, started on topical and oral medication after copious irrigation till the pH got neutral. On day 2, day 3 and day 4, visual acuity improved and continued with the same treatment. On right eye, stain positive epithelial defect ranges from 2 to 7 o'clock position with corresponding clock hour of limbal ischemia was present, and in left eye, 5 to 7 clock hour of stain positive epithelial defect with corresponding clock hour of limbal ischemia present. In both eye, macrocystic corneal edema with DM folds present. Subsequently, patient was planned for both eye tinoplasty with embryonic membrane graft after getting discharged from the burn ward. But as the visual acuity improved, a patient was lost to follow-up. 1 week later, he reappeared and for admission with a visual acuity of 360 in right eye and 2/60 in left eye. In right eye, a periocular burn in adnexa are present, and eyelids crusting of the lid margin and lashes, eye opening was improved. On ocular surface, in right eye, non-healing epithelial defect was present, and in left eye, conjunctival ischemia with 5 to 8 o'clock and was present, and early healing of epithelial defect. Clinical diagnosis of ocular surface burn of both eye with DOA grade 3 in right eye and DOA grade 2 in left eye was made, and advised for right eye tinoplasty with embryonic membrane graft under LA was done. On post-op day 1, visual acuity was in right eye was 2/60 and left was 6/24. In right eye, Tennant's graft, AMG and VCL was in C2, and left eye, since epithelial defect was healing, no surgical intervention was done at that time. Patient was discharged on oral and topical medication as previous. On first day follow-up visit, right eye corneal edema decreased, no limbal ischemia was seen, and AMG and BCL was in C2. But in left eye, BCL was missing, and IP defect was from 5 to 7 o'clock was present and was in healing. Periocular burn was healing, and upper and lower lid contractures started appearing. Left eye BCL application was done, and both eye lid tapping at night was advised. On second post-op follow-up visit, visual acuity in right eye was 360 and left eye was 618. And right eye lid contracture seen. Exposure keratopathy with epithelial defect was seen. Right eye median tarsography was planned since there is exposure keratopathy. And in left eye lid contracture seen, but lid closure was adequate, so epithelial defect was healing. Further test is due to lead contracture, tarsography opened in after 4 days, and further patient is planned for scar release and ectropion correction. Conclusion, ocular vitreolysis is true ophthalmic emergency with significant ocular morbidity and may lead to the complete and partial blindness. Its effects are devastating physically, emotionally, mentally, socially, and economically, and they stayed with the victim throughout their life. Severity depends on toxicity of the agent, time of contact, area of ocular surface involved, extent of ocular penetration, and while managing an ocular vitreolysis or any chemical injury, early and prompt treatment is very crucial, since even after good management, long-term sequelae affect the outcome. Goals are intervention in acute stage are copious irrigation to get rid of any residual chemical in the eye and achieve quick epithelial cover over the ocular surface to achieve the above goal. The bitter truth is that the incidence has increased over years, and it is soundly entrenched in our society. On the brighter side, surgical care has improved and evolved. Most importantly, society is now aware and playing an active role. Thank you.
I think this case represents an excellent management of the coordination between IGIMS and PMCH, and this is as that should be, because you've told that the patient was referred to PMCH and admitted in the burn ward of PMCH too. And at the same time, you've told us about the per day improvement in vision after admission. I think that the patient came back to you per day, or did you get from the records?
He was in daily follow-up with us. He was admitted in burn ward.
So he used to come back to you every day for follow-up. That's unique. I mean, that's as it should be. I think all our institutes are, whether small, big, or whatever, primary, secondary, and tertiary, throughout the state need to coordinate with each other. Excellent. Thank you.
Thank you.
Now I would like to call Dr. Priyanka Mohanty for her next presentation on lupus retinopathy.
Again, it is requested to every speaker, please adhere to your allocated time. और एक मिनट कम कर दो.
Good afternoon, everyone. I'm going to present a case discussion on from eye to system lupus retinopathy in a new SLE case. There is no financial disclosure or conflict of interest. As you know, SLE is a chronic autoimmune disorder which causes systemic inflammation, and it primarily affects women of childbearing age. And the ocular involvement occurs approximately 1/3 of the cases, but it is often under-recognized. And the spectrum ranges from mild dry eye disease to severe like vasculitis, choroidopathy or optic neuropathy. And the risk factor for ocular involvement are presence of nephritis, APLA, hypertension and female gender. Ours was a case of 20-year-old female who presented with progressive diminution of vision in both eye for past 2 weeks. It was associated with ocular discomfort and occasional floaters, but there was no prior history of trauma or prior ocular surgery or any diagnosed systemic illness. On general examination, a malar rash was prominent that was worsened with sun exposure on both cheek malar area, present over past 1 month. And she also had complaint of intermittent joint pain and stiffness and fatigue and occasional low-grade fever. No significant past medical history was there, and she was not on any medication. Menstrual history was regular. There was also no history of abortion or current pregnancy. On ocular examination, the visual acuity in right eye was finger counting at 1 meter with PR accurate in all quadrant, and in left eye it was finger counting at 3 meter. IOP and anterior segment was within normal limit. On dilated fundus examination, we found that there was tortuous retinal blood vessel, macular edema and multiple cotonool spot in both eye, more in right eye than left. On further systemic investigation was done, and she was found to be positive for anti-nuclear antibody, anti-DHDNA antibody. Complement levels were low and ESR CRP was elevated. On further ocular investigation, fundus autofluorescence was done, and along with OCT macula. On it we found macular edema in both eye, more in right with central macular thickness of around 375 micron and multiple intraretinal cysts. The patient was primarily referred to the medicine and rheumatology consultation, who started oral steroid and oral aspirin as an anticoagulant. Then the patient was lost to follow for 1 month and then presented to us with increased visual acuity of right eye 6/36 and 6/9 partial in the left eye. The systemic medication was continued and OCT macula was done for follow-up, and as you can see here, there was a plaque formation in the right eye, but the left eye macular edema has resolved. So coming to discussion, what I want to highlight in this case that early onset lupus retinopathy in a 20-year-old at initial diagnosis is quite uncommon, and the retinal changes suggest that it is an immune-mediated vasculopathy, and the ocular involvement predicts higher morbidity and mortality in the systemic disease. Also, we should not jump to conclusion of starting HCQ right away, and the initial acute phase is managed with systemic steroid and systemic immunosuppressive therapy, and multidisciplinary management is quite essential in these cases. And the contraindication for starting HCQ, as in this case there was presence of macular edema, so HCQ clearance was not given. And if there is any allergy or established maculopathy, we should not start HCQ in a case of SLE. And if we are starting HCQ, if there is no additional risk factor, we should begin monitoring after 5 years of drug therapy. And if there is additional risk factor, like if you are using increased dose of more than 5 milligram per kg, or there is impaired renal function, we should start monitoring after 1 year of therapy. So I would like to conclude saying that ocular manifestation can reflect overall disease activity, especially in young patient with unexplained visual loss. Lupus retinopathy may indicate vasculitis or antiphospholipid antibody syndrome that require urgent systemic evaluation for the benefit of the patient, and the prompt systemic immunosuppressive therapy can reduce the need of any invasive ocular procedure like giving anti-VEGF or something. So collaboration between multidisciplinary management is quite crucial for optimal patient outcome. These are few of the similar studies who had started steroid that is resulted in resolving of macular edema instead of any invasive therapy. Thank you.
I think this case very nicely demonstrates how an investigation and a treatment, a primary treatment of a SLE patient can be done by the rheumatologist, a general physician, and it can have a bearing on the ocular condition of the patient too. Thank you, Dr. Priyanka.
Next, Renuka J. Na?
Good afternoon, everyone. Today I'll be presenting a case on the topic unmasking the peripheral iridotomy. No financial interests or conflicts to disclose. India accounts for 21 million primary angle closure suspects. Laser iridotomy was considered to benefit the entire angle closure spectrum. Complications like dysphotopsia, hyphema, and cataract progression and transient IOP spikes have been reported after laser iridotomy, and rarer complications like choroidal effusion, malignant glaucoma were also being reported. IOP spikes post-iridotomy or due to IR energy, increased number of burns, and the trabeculitis due to the inflammation. Here we discuss an unusual cause of IOP elevation post-laser iridotomy. This is a case of a 23-year-old male who presented with chief complaints of pain in his right eye for the past 1 week. History of presenting illness: he was apparently well 2 months back when he had diminution of vision in right eye, which was insidious in onset and gradually progressive. History of pain in right eye for 1 week, sudden in onset, associated with redness. There was no history of trauma, photophobia, or colored halos. Previous medical records suggest that he went to a nearby hospital for the pain, and his recorded IOP was 55 millimeters of mercury, and he was started on topical and oral anti-glaucoma medications. There was no other systemic illness, no previous ocular intervention, or no family history of glaucoma. The current medications he was taking was tablet acetazolamide, eye drop brimonidine with timolol, and eye drop moxiprednisone. And his general examination was completely within normal. His presenting visual acuity was in right eye was perception of light positive with PR inaccurate. IOP by GAT was 44 millimeters of mercury. Lids and adnexa were normal. Conjunctiva had showed mild congestion, and cornea was hazy. The anterior chamber was deep with a translucent material seen as a clump with dispersed pigments, possibly suggestive of vitreous could be seen in the AC, and iris was normal. Pupils were mid-dilated, and RAPD was present. And the disc showed a near total cupping, margins regular, and rest fundus was within normal in right eye. The summary was a 23-year-old male presented with complaints of pain for the past 1 week, which was sudden in onset. He had a history of diminution of vision in the right eye for 2 months, insiders in onset, gradually progressive. His presenting IOP was 55 millimeters of mercury and was started on topical and oral medications. On anterior segment examination, we could see a clump of vitreous with dispersed pigments in anterior chamber, and the disc showed near total cupping. Our management was initially to control the IOP. Mannitol was to be started for the patient, and tablet acetazolamide along with the topical anti-glaucoma medications were added. Investigations: after controlling the IOP, we went for gonioscopy and anterior of the angle, as nothing could be seen in the anterior chamber for the cause of vitreous in the AC. This is the gonioscopy structure. Angles were open, but few pars could be seen in all the quadrants. And when we went for the anterior imaging of the same patient, a PI could be seen in the periphery of the iris. We couldn't see that clinically because the patient's pupil were dilated and RAPD was present. And the anterior shown a vitreous clump, as well as in the lower image you can see the iridotomy could be seen, and vitreous is prolapsing through the iridotomy opening. From this we arrive at the diagnosis of right eye secondary open angle glaucoma probably due to the vitreous prolapse in anterior chamber post laser iridotomy. We have even with medical management, his IOP was not under control, so we had to take him for a surgery. The surgery we performed was right eye anterior vitrectomy with surgical peripheral iridectomy under local anesthesia under the mannitol cover. This is the introp the gonio being done. In the gonio we could see the peripheral iridotomy with the dispersed vitreous with the pigments could be seen at from the PI side. And this is the video showing at the level of PI site. We need to remove the pars, we need to do using the spatula, we need to swipe off the iris. And post swiping of the iris, this is the post-op picture on the right side where you can see the peripheral iridotomy. Post-operatively on day 1, his IOP was still elevated. He had to be started on steroids, anti-glaucoma medications, both oral and topical. And on POD 1 week also his IOP was still on the higher range. And with the continuous use of steroids and topical anti-glaucoma medication, now with one anti-glaucoma medication, his IOP is under control, 12 mmHg, with no improvement in the vision. Discussion. NDR glazes basically act by photodisruption, which creates a plasma, and chances of bleeding and pigment dispersions are more with the use of NDR glazes. Pupillary block due to vitreous prolapse is a rare event that can cause a faster IOP elevation. Particularly in predisposed individuals who is pseudophakic, or in case where previous surgery has been done where the hyaloid is already disrupted. Angle closure due to vitreous prolapse post YAG capsulotomy has been already reported. And Kim et al. Has highlighted the therapeutic effects of doing vitrectomy, anterior vitrectomy in case of IOP arise due to vitreous prolapse in the anterior chamber. Take home message: laser iridotomy should be performed only on definitive indications. Laser should be avoided in early post-operative period and in acute IOP spikes where chances of your vitreous prolapses and your anterior hyaloid face is already disturbed. Lasers should be performed with caution in predisposed population where in cases of trauma or with dialysis. Identifying the cause of elevated IOP and timely management is crucial. ASOCT and anterion are helpful in cases where media haziness limits the value of gonioscopy. Thank you.
Thank you, Dr. Renuka. And thank you, Dr. Uskar and Swani ma'am, for nicely concluded this session. And thanks to all speakers. Every case was
thank you,
different and well presented by every speaker. Now we are going to start our very important session, vast session and new advancement. Definitely we will learn something new from this session. May I request moderator of this session, Dr. Tania and Dr. Prasun Kumar, and chairperson, Dr. K.S. Gupta sir, Dr. Pranav sir, sir, यही बैठे रहे सर, चलो आप ये सर में, N.K. Jain sir, Dr. Subrato Mukherjee sir, Dr. Ajay Sinha sir, please sir आइए sir, Dr. S.K. Pandey sir, Dr. Ajit Kumar Dwivedi, Dr. Prakash Tiwari is not here, Dr. Sachin, Dr. Sanjeev Kumar, Dr. Ankita C, नहीं है, Dr. Chandrasekhar, Dr. Ashish, Arvind Kumar, हाँ आइए अमिताभ जी, तो और पूछिए, सही है, Dr. Saroj, Dr. Rajesh sir, sir आइए, संजीव जी, चलिए, आप भी आइए सर। इस बीच में सुमंतो सर 10 सेकंड का टाइम लेंगे सर।
मैं सिर्फ 1 मिनट समय लेते हूँ। कल हमारे एक्वाइन का जो पीजीटी सेशन हुआ उसमें 2 रनर्स अप थे, एक थर्ड, और उस समय चला गया, उसका कॉलेज में काम थे, तो उनको अभी वो प्राइज़ दे देंगे, और 3 को जो प्राइज़ मिला 3 को एक साथ में एक फ़ोटो खींच लेंगे। तो मे आई कॉल अपॉन डॉक्टर Sana Parveen, Dr. Sana Parveen, she got the 3rd prize in rapid fire session. Sana Parveen. उनको दे दो। She also received Professor Gyan Bhaskar, Equine Bihar State Chapter 3rd Best of the Best Opthal PGT Trophy. तो उनको ये ट्रॉफी हम लोग देते हूँ, उसी के साथ डॉक्टर ज्ञान भास्कर को फोटो लेकर के जो साइटेशन है वो भी मिलते हैं। तो मैं 2 कॉल जो फर्स्ट और सेकंड हुआ वो लोग को बुलाते हूँ। खड़ा रहो। तो एंड डॉक्टर अमित राज, द मोस्ट सक्सेसफुल प्रोफेसर एंड HOD ऑफ एम्स पटना, क्या के काल इनको ही 2 ही पीजीटी बेस्ट ऑफ द बेस्ट एंड सेकंड बेस्ट ऑफ द बेस्ट, डॉक्टर के तिवारी बेस्ट ऑफ द बेस्ट ट्रॉफी, डॉक्टर सत्य प्रकाश तिवारी सेकंड बेस्ट ऑफ द बेस्ट ट्रॉफी ऑफ बिहार पीजीटी इन ऑप्थेल्मोलॉजी मिला। ये 3 गो को, यार 2 फर्स्ट एंड सेकंड उन्होंने डॉक्टर अमित जी का ये है पीजीटी है। एक साथ इनको एक फोटो हम लोग ले लेते हैं। थैंक यू सर।
हो गया ना सर? थैंक यू सर।
सर हम लोग की तरफ से भी
शिवेंद्र साहा
कांग्रेचुलेशन।
सर प्लीज सर आइए ना सर, शिवेंद्र साहा सर प्लीज।
हाँ ये बात अब बढ़िया हो गया।
तानिया
नहीं, जल्दी जल्दी हो जाएगा।
सो
हाँ बस तुरंत एकदम।
मैं रिक्वेस्ट रवि रंजन सर एकदम बिल्कुल एक जोरदार ताली बजाए सर के लिए, उसके बाद फिर तो सर बोलबे करेंगे।
So welcome everybody to session 7.
खत्म करना है
बस तुरंत खत्म कर
So
लें।
welcome everyone to session 6, and we start off with the keynote address by Dr. Ravi Ranjan. Congratulations
Thank
to
you,
you
sir. Thank
for
you, sir.
organizing, and to Amitabh for organizing such a wonderful conference.
One thing I want to say, sir, whoever not got their souvenir in travel card form, they can receive it from NRI registration counter.
So you have got 6 minutes time, Dr. Ravi. Role of
sir.
sodium hyaluronate and trehalose in eye drop in dry eye management.
Thank you, sir.
Please.
This one is sponsored by JV Chemicals. And here is the definition of dry eye. Dry eye is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film and accompanied by ocular symptom in which tear film instability and hyperosmolarity, ocular surface inflammation and damage and neurosensory abnormalities play etiological role. And this is the dry eye prevention, and this is dry eye prevention in India. The prevalence of DAD in India is higher than the global prevalence and ranges from 18.4% to 54.3%. To enhance lubrication and prolong the retention, artificial tear remains the mainstay therapy for the management of dry eye disease. And to enhance lubrication and prolong the retention time on the ocular surface, a variety of viscosity enhancing agents are frequently incorporated to the artificial tear. And the evolution of tear film is very important. There are four generations of tear substitute. I am skipping it to save time. And the most commonly used viscosity enhancing agent in nowadays is sodium hyalurate and trehalose. Skipping this slide. Sodium hyalurate is a glycosaminoglycan linear polymer composed of long chains of repeating disaccharides unit of N-acetyl glucosamine and glucuronic acid. Actually, this slide is prepared by the JB peoples, and first time I am going through it. And what are the glycosamine can negatively charged polysaccharide compounds, and functions are play a key role in the cell signaling and cell adhesion and wound repair. Role of the sodium hyalurate in dry eye is it effectively binds water and resists dehydration, promotes epithelial wound healing and viscoelastic property enhancing residence time. And why HA effectively bind to water? Owing to the large number of negative charges on the molecule, sodium hyalurate is capable of holding large quantities of water and thus lubricating surrounding structure. And here is a 1 gram of hyaluronic acid can hold up to 6 liters of water. How does hyaluronic acid promote corneal wound healing? I am not going in detail. And the viscoelastic property of hyaluronic acid is just escaping this, sir. Role of trehalose in the management of dry eye. It stabilizes protein and membranes, prevent denaturation and inhibit oxidative damages, and osmoprotection. Protects cell under extreme osmotic stress by balancing the osmotic pressure without disturbing cell metabolism. Sir, these all are written in books, that's why I am just escaping these all. Actually, a role of sodium hyalurate and trehalose combination in the management of dry eyes, and result is they dual benefit. And after cataract surgery, significant number of patients report symptoms associated with dry eye following surgery, with 87% of patients describing symptoms in the first post-operative week, 35% after 3 months, and 10% patients developing chronic dry eye. And this combination is particularly true in elderly patients where the prevalence of preoperative subclinical or clinical dry eye is high, and cataract surgery aggravates these signs and symptoms. Can I escape, sir? There are many studies here. This slide is that way key. And the key takeaway is artificial tear are the mainstay treatment for the subtype of DAD, improving symptoms by mimicking natural tears. And the second is hyaluronic acid. A viscosity enhancing agent improves lubrication and extends the duration of tear retention on the ocular surface. And the third is trehalose is an osmoprotection agent that preserves the integrity of the ocular cells through control of inflammation. Thank you. Thank you.
Thank you, Dr. Ravi. I mean, one of the most important factors apart from the lubrication and the viscosity is the anti-inflammatory effect of sodium halonate and the trehalose, both of them. See, yeah. So that is one aspect which is taken care of apart from the lubrication. So that cuts down the this vicarious cycle that sets in dry eye. So that is, yeah, exactly. So it's a very good molecule combination. So, next speaker.
Thank you so much, sir, for your insightful talk. Our next speaker is Dr. Mohammad Akhlaq Akhtar, sir, who is going to present on the topic Artificial Intelligence in Cataract Surgery, Present and Future Perspective.
Good afternoon, everybody. I will be quick. So I'm talking on artificial intelligence in the cataract surgery, no financial disclosure. So first we start with the terms. The artificial intelligence is the machine's ability to perform cognitive functions as humans do. Now another term is the machine's learning, which is a subset of artificial intelligence where the machine learns from data and improve with the experience. And third term is the deep learning, which is a subset of the machine learning that utilizes neural network to analyze complex data. Now with that said, we understand why ophthalmology is suitable field for AI application, because it is a very image-rich specialty with overwhelming patient burden and shortage of expertise, and AI can be seamlessly integrated with telemedicine. So the importance of data is that the capabilities of the AI system is heavily reliant on the data they are trained upon. So a highly accurate and well-labeled data sets are required. If the input is garbage, the output will also be garbage, that is the GIGO. Now, AI systems are data hungry. They require a large amount of data for the learning, and also AI systems has to be trained on diverse data sets. The goal is to enhance the clinical safety and improve the efficiency and the quality of the patient care, as well as overcome geographical barriers in the care delivery. So how could AI help in the cataract management? In the pre-op, it helps by diagnosing and grading the cataract as well as calculating the IOL power. And most importantly, it also optimizes the OT workflow and scheduling. While in the intra-op, it gives a real-time surgical guidance and also a skill assessment, and also prediction of the intraoperative complication. In post-op care, it gives smart scheduling systems and evaluating the patient recovery, and also predicts and detects some post-op complications. So how it diagnoses the cataracts? By analysis of the various types of ocular images, like the fundus image, the slit line photograph, and photos by the smartphone apps. The role of AI in IOL power calculation is to optimize the calculation by formulas like the Kane, Pearl, DGS, Hill, RBF. The advantage is that one formula adapts to different eye lengths. No need to apply one formula for hypermetrope and other for the myopes. It also overcomes the challenge in calculating the IOL in post-refractive surgery patients, and also for aligning the toric lenses, and also optimize the IOL inventory. So how does it assist during the cataract surgery? By detecting the instrument and movement tracking, enhanced visualization to improve the visibility of the crystalline lens, and surgical guidance tools. It also helps in training by AI simulators like Help Me See simulator to assess the performance, and also giving real-time feedback, and also prevents the complications by predicting problematic events. It is also helpful in post-care by smartly scheduling the follow-up visits and automated patient follow-up. Thus, it increases the convenience and reduces the number of in-person clinical appointments. How does it do? Well, autonomously initiated follow-up call is given, and some questions are asked. And if any issues are identified, then a face-to-face consultation with a specialist is appointed. These are some of the models which are employed in the cataract surgery. The current application of AI in India is smartphone apps like eParvai and eRoshni, which are used for the cataract diagnosis and grading. So what is the need in the ophthalmology? It is for addressing the patient overload and bridging the expertise gaps, as well as automate repetitive tasks. So, overcoming the rosy picture, we have some challenges which hinder the widespread use of AI. That is the lack of high quality and diverse training data. infrastructure and funding constraints in resource-limited settings, and limited clinical adoption, trust, and human AI interaction. Most importantly, the black box nature, that is the decision-making process are opaque and difficult to understand. Why does the AI flag some patient as glaucoma, though I am seeing it is normal? So this is a black box feature. Some ethical concerns are concerned about the patient data confidentiality, liability, who bears the responsibility when the AI makes an incorrect diagnosis or recommendation. Does AI make me a better ophthalmologist? Well, it augments, not replaces the human judgment. It enhances the diagnostic accuracy, provides surgical guidance, can automate repetitive and boring tasks, thus freeing up time for the clinician for more direct human interaction with the patients. So will AI replace the ophthalmologist in the future? At present, the role is to complement the skill of the doctor, not to replace them. The physician has the final call for the decision and management plans. But AI lacks the emotion and the ability for out-of-the-box thinking. Empathy and care provided by the human doctor is indispensable. And thank you for listening.
Thank you so much, Doctor, for your insightful talk. Our next session is by Dr. Vidya Nidhi. She is going to...
Yes. At present, it is by some arts.
It is not a diagnostic tool because cataracts operation management of cataract depends upon the severity of the cataract.
Yes.
For one patient, it is normal, and for other patients, it is very important to go for cataract operation.
Yes.
The best part is the calculation of IOL power.
Yes.
That should be done because in IOL power we have Barrett's, but in the IOL it is Keynes formula. It is also there are Hill RBF formula. These are the good formulas to, and one should, at least for the long eye and short eye, one should go for these formulas because Barrett in those cases are not good formulas.
Right.
So for the management of cataract, go for the IOL power calculation.
Absolutely right, Dr. Agarwal. What you said, artificial intelligence, especially the Keynes formula, is extremely good in extreme cases. And
this was on my paper. It was the best.
yeah, I know that. Because artificial intelligence as such in ophthalmology is mostly confined to glaucoma and retina, diabetic retinopathy, glaucoma management, glaucoma diagnosis. Diagnosis as such, I have not come across a diagnostic value of artificial intelligence, but it holds lot of value, it holds lot of future. So very nice insight. Thank you so much.
Our next speaker is Dr. Vidya Nidhi. She is going to present on the topic Seeing the Unseen, the Potential of Smart Contact Lenses.
Vidya Nidhi is absent.
Dr. Vidya?
Vidya is not.
Dr. Vidya is... हो गया sir. Dr. Vidya is not sir.
We next move to the next speaker.
Neetu Sinha.
Okay. Dr. Neetu Sinha is going to present on the topic Bridging the Gap by Teleophthalmology in Low Resources Area.
उससे और आपको पता था.
So, good evening everyone. My topic is Bridging the Gap by Teleophthalmology in Low Resource Area. So, I have no financial interest. So, ophthalmology is largely an image-based branch. Less number of ophthalmologists in comparison to population of India. India's internet subscriber base is of 560 million, potential to replace half of the outpatient consultation in the country. So our country scenario is 1 ophthalmologist per 1 lakh population. 70% of them practice in urban areas. More than 80% of the healthcare resources are in urban area. But 70% of population resides in rural areas. So the issue for eye care in India, first, shortage of doctors. India is one of the countries which suffer from shortage of doctors. Inadequate infrastructure of roads, communication, transport and financial status of the patient make it even more difficult to provide healthcare in rural areas. So in recent years, there has been exponential growth in information technology. In order to make eye care services accessible to everyone, the concept of teleophthalmology has came into existence. So what is teleophthalmology? It is a branch of telemedicine. It allows clinicians to provide quality healthcare benefits outside of clinic through digital technology, thus improving access to medical care, patient outcome and satisfaction. So why it is needed? Because the problem of 80% of vision threatening disease leading to blindness are caused by cataract, glaucoma, refractive error, diabetic retinopathy, AMD. So 80% of the blindness can be prevented if pre-screened. So the teleophthalmology with the most appropriate solution to bridge the gap. So the objective is to make the eye care services accessible and affordable by reducing travel costs and time for the patient, to enable people of remote areas to have access to specialized eye care facilities. So scope of teleophthalmology for the specialist opinion, eye care in rural area, eye screening in school for the children, diabetic retinopathy and ROP screening, teaching, training and awareness program. So the concept of teleophthalmology: registration of the patient, examination of the patient, vision, slit lamp and fundus photography. The images are then sent online, images are accessed by the ophthalmologist, reports are sent by the email, and the patient with inconclusive report are referred to ophthalmologist for the medical or the surgical treatment. So this picture shows how the patient examination was done at the vision center and how teleconsultation work. So the modes of communication include by the video call, WhatsApp, FaceTime, audio call, by the telephone, WhatsApp calling, text-based messages, and by the email and the fax. So the tools include the mobile teleophthalmology unit, anterior segment digital camera, digital fundus and OCT, RedCam, and the video conference unit. The mobile unit, they are equipped with fundus camera, slit lamp, and ophthalmology software, and many more. Anterior segment digital camera used in accident and emergency setting. High resolution fundus photograph and OCT scans are taken for retinal screening, and the images are graded for retinopathy severity, and arrangement are done if referral is needed. A RedCam is used for screening of ROP and retinoblastoma. Video conferencing unit allow face-to-face interaction and inspection of the emergency cases. So teleophthalmology are used in various conditions like adnexal lead disease, cataract screening, diabetic retinopathy, glaucoma, AMD, ROP, refractive errors, and many more. So the eye care devices in remote area for diabetic retinopathies, handheld fundus camera, refractive error, handheld autorefractometer, cataract, handheld slit lamp, and glaucoma, tonometry, and tonopen. So teleconsultation has gained popularity during the COVID-19 pandemic. It is preferred as it is safe and doctor can see the patient directly, reduces the exposure risk, time, and travel costs. So teleophthalmology project in India, eSanjeevani app. It is user-friendly, independent platform, browser-based, allow both doctor to doctor and patient to doctor teleconsultation. Arvind Teleophthalmology Network is designed to screen diabetic patient. So the study showed population with diabetic retinopathy, out of which 30% of the patient are not even screened for the diabetic retinopathy. So project by Shankar Nethralaya Medical Research Foundation at Chennai provides ophthalmic examination. MDRF WDF Rural India Diabetic Projection Project designed for diabetic screening. So two mobile teleophthalmology units, Sunayanam commissioned in 2011 and Nayanapadan commissioned in 2012. So the advantages include real-time consultation by professionals, save cost, time and effort, avoid unnecessary referrals, extensive outreach is possible, timely intervention in emergency situation, health education and awareness. So the challenges include connectivity and infrastructure, high cost of equipment and maintenance, lack of trained personnel and staff, detailed examination is compromised and loss to regular follow-up, maintaining sustainability as it is a new is a major challenge. So medico-legal aspect, no clear medico-legal guidelines are available, valid for those residing in India only. Digital e-signature for dispensing medicine. A detailed disclaimer should be mentioned on the prescription. Data storage and privacy is important, and teleconsultation of minor should be done in presence of adult attender. So the take-home message is that teleophthalmology offers a transformative solution for delivering eye care facilities in low-resource area by bridging the gap between the patient and the specialist. It enables early detection and timely referral. It reduces avoidable blindness, and teleophthalmology is the future of accessible, scalable, and high-quality eye care facilities. Thank you.
Very excellent and very informative presentation.
Thank you so much, sir.
It's an eye-opener.
Thank Thank you, sir.
It's not a new branch. Now it is a relatively old branch because it came into sight during the
Yes, sir.
pandemic,
Pandemic.
COVID pandemic.
Yes, sir.
And that is not going to replace our traditional kind of
Yes.
examination, but it has a supportive role,
Yes.
definitely, no doubt about it.
Yes, sir.
And artificial intelligence, the first speaker who spoke so well, that also has lot of role with teleophthalmology.
Yes, sir.
Both of them together,
Together.
they have a future.
Yes, sir.
Thank you so much.
Thank you so much, sir.
Photographs.
What?
In the teleophthalmology,
Huh?
only to compare
No,
the-
if you have got a good resolution photograph,
yes.
you can compare because
Yes,
if you go
then
deep
we
into
can go
artificial
for
intelligence, what it does, it breaks the photograph into pixels. It gives numbers to it.
Yes, numbers.
2, 3, 4, 5 like that. And
Yeah.
those data, they are collected and they are compared and recreate
yes.
a picture that you get and then compare it. So
Okay.
that is possible with
Now,
high resolution.
Good photographs is essential.
Yeah, good
for
photograph,
artificial
good
intelligence
photograph,
comparison.
good data is essential. It is all data driven.
Yes, so the connectivity is very important.
Yeah.
Thank you, sir.
Thank you.
Our next speaker is Dr. Tania. For those who don't know, I must introduce her. She is daughter of Dr. Pradeep Karak, our ex-president. So Dr. Tania will be speaking on
Thank you so
comparison
much,
of central corneal thickness measurement by contact and non-contact pachymetry devices.
Thank you so much, sir, for giving me the honor to present on the topic of comparison of central corneal thickness by contact and non-contact pachymetry. No financial interest or conflict of interest. Introduction. Central corneal thickness is an important clinical assessment in the diagnosis of corneal disease such as glaucoma, keratoconus, edema caused by contact lens use, pseudophakic or aphakic bullous keratopathy and endothelitis, and many more conditions. A 10% change in CCT alters intraocular pressure by 3.4 mm of mercury, and correcting for CCT is necessary to accurately measure the intraocular pressure. In glaucoma, a thin CCT is a significant risk factor for intraocular pressure underestimation. Central corneal thickness varies extensively in normal subjects. The mean CCT is around 511.4 plus minus 33.5 microns. This study aims to compare the CCT measurement and determine its reliability between non-contact pachymeter and standard handheld ultrasound pachymeter clinically. Ultrasonic pachymetry is commonly used and regarded as gold standard. It is based on reflection of ultrasonic waves from anterior and posterior corneal surfaces. It is the time difference, which is also known as the transit time, between the ultrasonic signal from probe's transducer and reflected signal from front and back surfaces of cornea to the transducer. Non-contact pachymeter has been developed in the recent years using a specular microscope method. Materials and methodology. It was a hospital-based comparative study conducted in the outpatient department of ophthalmology. CCT measurements were taken by ultrasound pachymetry and non-contact pachymetry for 52 subjects, which includes 104 eyes, out of which 25 participants were male and 27 participants were female, aged between 15 to 40 years of. Entire steps and purpose of the study was explained thoroughly before conducting the survey, and informed consent was taken from the participants. Subjects having no sign of ocular pathology were included in the study. Subjects on topical medication, history of ocular surgery, laser procedure were excluded from the study. Corneal thickness measurement was first taken by non-contact pachymeter. Following this, the cornea was anesthetized with topical 0.5% proparacaine, and 5 readings were taken with ultrasonic pachymetry. All the readings from non-contact pachymetry and ultrasonic pachymetry were taken by a single trained person. The highest and the lowest were excluded, and the mean and standard deviation of the remaining 3 were used for the analysis. Now coming to the result. In this diagram we see the mean value of CCT by contact pachymeter was 534.56 micron with the standard deviation of 39.02 micron, while the CCT by NCT, the mean value was 529.15 micron with having standard deviation of 38.55 micron. The mean difference was 5.40, having p-value of 0.316, which is less than 0.05, which is insignificant. Discussion. The present study was conducted to measure and analyze the central corneal thickness by two different instruments in 104 eyes of 52 subjects. Various methods are available to measure CCT, including ultrasound, specular microscope, tonopachymetry, optical coherence tomography, interferometry, confocal microscopy, and corneal tomography. Ultrasound pachymetry has very high repeatability and has several advantages such as speed of use and portability. Due to the contact nature of the handheld ultrasound pachymetry, the chances of epithelial defect and the chances of incorrect measurement due to the user and non-contact methods have been preferred more recently. As we have seen in the previous table that CCT was 5 micron thicker by gold standard ultrasound pachymeter as compared with non-contact tonopachymeter, p-value being 0.316, which is insignificant. Conclusion: our study concluded that the difference in the measurement of central corneal thickness between non-contact tonometer and contact pachymeter were statistically insignificant, and the same can be used interchangeably for CCT measurements. These are the references, and thank you.
Very nice presentation, Dr. Tanya.
Thank you, sir.
I just want to know what was your rationale using Paracane or non-contact tonometry methods?
No, so I was using Paracane contact tonometer.
There it was there in the. If it is contact, then it's okay. If it is non-contact, then we could not understand. One thing more,
so
CCT is very important in context of glaucoma. In Hindu rituals, we have to remember two things, 51 or 21. So for 21 mm Hg, the reference is 510 micron. So for every rise of 10 in CCT, according to Pilanat factor, 0.5 rise is there. So when we were UG or PG, we thought that the 20 is the bar mark. Now a patient having 600 micron and if his or her pressure is 24 mmHg, even then the patient is normotensive, because as per Pilanat factor, the pressure for that 600 micron corresponding upper normal limit will be 25.5. So this is very important, and this has revolutionized the concept and diagnosis of glaucoma in the initial stages. We cannot miss. We have to, in every workup of glaucoma, we have to consider the CCT, the pachymetry. And we have three methods of, mostly in our practice. Anterior segment OCT, biometer, and this topographer. With these three, we use the non-contact, and it's very handy, very faster we can do the things. Thank you very much. It was a very nice presentation.
Our next presenter is Dr. Nilesh Kumar.
Thank you, sir. So thank you, viewers, for this opportunity and nice hospitality, Amitabh sir and Ravi Ranjan sir. I am going to present my innovation, BOD graph, that is the low-cost alternative to fibrin glue. These are my financial disclosures. And what are the current options of graft fixation in pterygium surgery available right now? It's suture, autologous blood, and fibrin glue. So comparing the autologous blood and fibrin glue, autologous blood is very economical, but again it is very prone to graft displacement and has retraction in it. And operative time is intermediate. Fibrin glue sometimes is good, but the cost is the factor, costing around 7,000 to 8,000 to the surgeon and more than 10,000 to the patient. So there has to be something in between. So what I thought was to use Botropase. I'll tell you why I use that. It is a hemocoagulase enzyme that was derived from Bothrop snake venom, and it is available actually commercially. The mechanism of action is through the fibrin glue, similar to fibrin glue action. It stabilizes the fibrin meshwork and stabilizes the clot. And the advantage is it is having rapid and strong clot formation. It is more consistent and reliable than autologous blood, much cheaper than fibrin glue, and also it is safe. So no risk of disease transmission. And the advantages in wound healing is there. It stimulates collagen fiber growth. So these are the commercial preparation available. One is 1 cu per ml, and one is 0.2 cu per ml. The topical drop is that I use, and this was the first use at our hospital. So this was a case of facial laceration. The patient was very apprehensive. He was a mukhya of the village, and he was very apprehensive that this scar is going to form. So what we did is put a drop of hemocoagulase and then use a tissue adhesive. So without any scar, it was completely healed, and the patient is very happy. 2 years into follow-up, and he comes every month just to say hello to us. And then we used also in cosmesis. As you can see, this patient was having a very bad facial trauma, and on the 7th day, that is the D picture that is there, you can see how beautifully the scar has healed, and after 1 month you can not make out actually it is there. So that is the beauty it is having in scar formation. So what I did, I also use it for DCR, and when I was using it for DCR, I put the drop, and then with the cotton tip I pulled out the clot, and I could see the fibrin strand that was forming, and then it struck that can we use it for pterygium surgery. So that was the first of the many innovation that should come out from Madhvi Nethralaya. This was the first one of that. So this is a routine pterygium surgery. We are excising the pterygium tissue subconjunctively. That is routine. So after that, what I do is put a drop of botropase at this time. What it does is it reduces the bare sclera. As you can see, I just left it there and it won't move. Till the end of the surgery, this conjunctiva is not going to retract at all. And this reduces the amount of graft that you need for conjunctival autografting. Now I raise the conjunctival autograft from the superior cornea, superior side, with some amount of limbal stem cell that is tried to be harvested. So that graft is now ironed out. The only thing that we need to make sure is there should be no fluid below this, and there should be minimal amount of oozing on which the Botroclot will act. So once it is done, we just lift it again. Now we will lift the graft, little bit of drying. Now you can see the fibrin strand have already formed, but again I'll put one more drop just to be more sure, and just put it back, and that's it. You leave it and it is not going to move. We have done around more than 80 cases 70 cases right now. With 10 months of follow-up, only one case had a little bit of displacement. And recently, this is the outcome, and it has also been published. And this case I did last week. So I thought that let's graduate and use it not on conjunctival autograft, but also with amniotic membrane. Let's see how it works. So similar case, cut it from neck and excise the conjunctival tissue. Remove everything from the tenons area. The complete bare sclera is there, and then the conjunctival, the amniotic membrane is cut to size, spread across, and just you can see I slid it over there, spread it, again cut the excess amniotic membrane. We won't leave anything on the cornea in this case, because there is a chance from there something can seep in and elevate the graft. So we will cut it to size, and then do the same thing, lift it up. I just skip. So inducing a little bit of bleed, put a drop of Botroclot, again spread it, and that's it. The case is done, closed, and this is next day post-op. The graft is still there, nothing else is required. Amniotic membrane is holding very well. And this surgical technique has been published. You can scan the QR code, or I can send it to you on your WhatsApp also. So to conclude, Botropase is a cost-effective, efficient and safe alternative for graft preparation in pterygium surgery. And its standardized activity and multifaceted action makes it a valuable adjunct in ophthalmic and other surgical field. Thank you.
Thank you, Dr. Nilesh. Well presented. My question is any difference between the autologous blood? Generally we use in pterygium surgery just prick the scleral vessel and let them bleed, and just it is beautifully autologous conjunctiva is opposed.
Yes, sir.
and there is no retraction or graft loss noted till date.
So,
If
sir,
done properly,
with
I will differentiate which one is better, autologous blood versus butropage.
So the main problem with autologous blood is two. One, it contracts. The autologous blood, that clot that forms, it contracts, and sometimes, like you see, after 1 week, there is a little amount of bare sclera that appears on the edges of the pterygium graft. With this, it is not going to happen because it is going to hold that thing. And also, there is less chance of graft edema that can occur, because in autologous blood, there is chance that the graft is elevated if there is heavy bleeding and it is not cauterized properly.
अभी ब्लीड होगा तो एडेयर ही नहीं होगा. एक्चुअल में क्योंकि आप भी कर रहे थे तो वहाँ पे some amount of blood.
Yes, sir. I have to leave some amount of blood on that. This water clot acts.
But any study?
So I have published the study, sir, and we are
comparable.
Comparative studies are a multi-centric trial. We are around a team of 18 doctors now that are trying a multi-centric trial all across India using this technique, and probably by the end of this year we will have some preliminary report out, sir.
Any inflammatory reaction noted post?
Not noted, sir, till yet.
This is a very interesting observation.
Thank you,
Very interesting activity.
Sir.
एक ही चीज़, water clot has been used by gynecologists a lot. I also
Yes, sir.
use water clot for sac surgeries.
Yes, sir.
I was not sure about whether it will have any epithelial toxicity if I use it directly on the eye. So that
Yes,
is
sir.
why one reason why I did not use a water clot.
Yes, sir.
But what you showed, there was hardly any epithelial.
Yes, sir. Nothing is there. sir.
Changes.
Last 1 year I am using it, sir. It is
Still
not.
so if it-
It is available with Jagat Pharma, sir, at 200
Jagat,
rupees.
yeah, it is
200 rupees, commercially available, sir. It is for 80 years. It is there.
And most of the gynecologists, they use this water
Yes,
clot during abdominal surgery. Huh? DCR हम उसी से लिए थे. I've been using it for nearly more than 5 years, water clot. But I've not used it for pterygium just for the fear, because it's not a eye drop, ocular drop.
So now, sir, they are the company is actually coming to our hospital. They are trying to actually formally launch it as
So if there is
ophthalmic drop.
if there is no adverse reaction on the ocular surface as such, I think it's a very good.
सर ये बेसिकली इंटरऑप्ट ऑर्बिटल हेमेंजियोमा वगैरह में इसको आयरन और ग्लू जो है सर, वो अगर ब्लीडिंग होता है तो ग्लू और बटरपेस्ट का.
Also, sir, facial trauma, just because it is your area of expertise, facial trauma, whenever you are prescribing Neosporin or any ointment, just put 1 drop of this mix and apply. Beautiful results, sir. No scar at the end of 1 week. No scar. All the abrasion, everything heals very beautifully.
Okay, thank you, Dr. Les.
Thank you, sir.
Thank you so much, sir, for sharing your knowledge with us. Next presenter is Dr. Anamika Sinha. Is she there? Okay. Moving to the next, Dr. Samisha Sabre. Dr. Nimish Kumar Singh. Okay. Sir is going to present on the topic multi-layered AMG in case of ocular Stevens-Johnson syndrome.
अमिताभ जी, रविरंजन सर को बुला लीजिए. Please start.
Good evening, everyone. Thank you to Bihar Ophthalmological Society for giving me this opportunity. So in this presentation, I would basically talk about the role of amniotic membrane graft in cases of cicatrizing conjunctivitis, and I will specifically show a surgical video where we have performed a multi-layered AMG in a case of ocular SJS. So briefly talking about amniotic membrane transplantation. So amniotic membrane is the innermost layer of the fetal membrane. It contains epithelium, basement membrane and stoma. It is a rich source of biologically active growth factors and promotes healing. It also acts as effective material for wound dressing in ocular and non-ocular structures. So talking about the individual layers, the epithelium provides cytokines that maintain microenvironment of the stem cells of the corneal epithelium. The basement membrane facilitates migration of epithelial cells, reinforces adhesion of basal epithelial cells, and prevents apoptosis. Whereas stroma modulates proliferation of normal corneal, conjunctival and limbal fibroblasts and reduce conjunctival fibrosis. So there are two techniques of amniotic membrane transplantation. First is overlay technique, which is used in large epithelial defect with or without stromal ulceration. So here the entire corneal, limbal and perilimbal surfaces are covered with AMT, and they are secured either with fibrin glue or interrupted 8-0 Bickel suture through cornea, or 10-0 running nylon suture, Bickel suture through the conjunctiva, or 10-0 nylon sutures through the mid-periphery of the cornea. Second is the inlay technique, which is used in localized persistent epithelial defects less than 20% of the corneal surface with or without stromal ulceration. In this, the inlay graft is cut to the size of the epithelial defect, and these grafts are placed with the epithelium side up, and they are secured to the edge of the defect by interrupted nylon suture or fibrin glue. Another technique is the multi-layered amniotic membrane transplantation, which is used in cases wherein there is significant stromal tissue loss. So in this, the first, especially in non-healing ulcers, so in this the bottom of the ulcer is debrided and poorly attached epithelium at the edge of the ulcer is removed. Then the amniotic membrane is cut into smaller pieces and stuffed into the ulcer. The second amniotic membrane is transplanted as a basement membrane. The third amniotic membrane is transplanted as a cover, and is also secured with 8-0 nylon or Vicryl sutures. So coming to our case, this is the case of a 19-year-old female which presented to us with redness, watering, photophobia in both eyes since 1 month. She had an episode of chickenpox 1.5 months back. So this is the picture of her right eye, which showed lid margin keratinization, symblepharon and pannus formation, and there was also central corneal thinning with stromal melt along with total LSCD. So here is the surgical video. Here we can see that first we have performed pannus excision. We give a nick at the limbus, and then we dissect the pannus just like we do a pterygium. And after the dissection, it's important to maintain, to clear the bleeding every time, because the surgical field should be clear. Then after dissecting the pannus, we also go ahead and we perform peritomy. Peritomy is important to stuff in the amniotic membrane graft, and peritomy is done all around the cornea, and after the peritomy, then we go ahead and we dissect the pannus which is on the corneal surface. So before taking these patients for surgery, it's important to do ASOCT to know the underlying corneal thickness, so that we don't inadvertently perforate the cornea. So after removing we have to remove the pannus from the corneal surface, because this will help in laying the AMT properly over the cornea. So the pannus is removed diligently from the surface, and now we dissect the remnant of the pannus from the sclera, and then we put the AMT. So the removal of the AMT is also important from the paper, nitrocellulose paper. So the epithelium side should be up. This is checked by sticking some cotton bud to the surface. If epithelium side is up, then it will not get stuck. Then we cut the AMT to the size of the defect. Now again we cut another layer, which is also trimmed to the size of the defect. This layer, as discussed, it acts as a basement membrane for the epithelium to grow. Alternatively, we can also roll this AMT into 2-3 layers and stuff into the defect. So here I am cutting another layer of the AMT to cover the first layer, and after this is cut, then we put the remaining of the AMT on the entire corneal surface like an overlay. So this is the and in the end the BCL is placed. So this is the first day picture of the patient. We can see the multi-layered AMT in the area of the defect, and the overlay AMT on the surface. And we prescribed topical steroids and antibiotics, and along with lubricants and cycloplegics. We kept the patient on close follow-up, and we are now planning to perform lid margin mucous membrane graft in the patient. So a similar retrospective study of 43 patients where of ocular SGS, they performed amniotic membrane transplantation in 72 dehydrated AMT was used and 13 cryopreserved AMT was used. So the visual outcome was good in all the cases, and there was no significant long-term complication in either of the groups.
So amniotic membrane transplantation, it controls inflammation and promotes epithelialization in ocular surface in cases of ocular means persistent epithelial defect, and in cases of stromal tissue loss, multi-layered AMT, it not only helps in filling the defect, but it also promotes surface epithelialization. So in cases with ocular SJS, the amniotic membrane transplantation, it reduces inflammation and also acts as a protective layer, protecting the ocular surface from the keratinized lid margins and other ocular trauma. Thank you.
Any questions from the audience? Okay. Thank you so much, sir, for your presentation. Our next speaker is Dr. Ashish Kumar. He is going to present on the topic DISSEC and complex scenarios.
Good evening, everyone. Thank you so much.
Ashish needs no introduction. He's such a great corneal surgeon. We all know him.
Thank you so much, sir, for that appreciation.
नहीं, before you start, एक question पूछना था with the last speaker. Where do you get the amniotic graft from? What kind of amniotic graft you have been using, and where do you procure it from? And can you use the fresh amniotic graft from a gynecologist, from an obstetrician? I mean, it is open to you also, because this interests me. हमको लगता है करना चाहिए.
So generally the amniotic membrane is prepared from the fetal membrane, and it is harvested. It can be harvested from the placenta itself.
Can you harvest it directly from the placenta of
yes,
the
and it's
of the
sterile
obstetrician?
also. And it's sterile also. We can use it. Logistic is the only issue, sir. Otherwise, I thought of it, but again, the requirement is also not every other day that I go and we have to go to gynecologist and get the placenta and then harvest and then use it. And you don't need to even sterile it also. It's sterile, so can be done. And we can also get a thick and a fresh, and the best amniotic membrane we can get fresh is same day from a gynecologist clinic.
Right. Okay.
The only problem is the logistic. You have to go and get it. So I'll just show two videos of DISSEC in complex scenario. So the first case is a re-DISSEC in a failed DISSEC graft. So I don't have a video of the first, that was my case only, which failed after 10 days. It was a primary failure, it never cleared. And surgically it was, I was quite confident that I've done a good job, but graft never cleared. Probably there was a problem with the pre-cut graft. Although it came from a very reputed institution, but there can be instance where you have a primary failure. The second video is post-keratoplasty. So this was the first, this is a pre-op picture of a primary graft failure, DISSEC. And so you can see a DISSEC graft which is there. Now I am just trying to detach the previous DISSEC graft and trying to take it out. Requires a couple of minutes to first detach, and then from the main wound, since it was quite some time, I attempted a regraft after 3 months. When it didn't clear, I could have done it before. The advantage of doing probably before would have been that patient would not have been sensitized to that antigens and could have helped. And I used the seeds glide technique, and then put a seeds glide and another DISSEC graft, and same it's an established technique. Hardly takes 15 minutes. Put a air bubble, you're done with the case, and put a suture. So I could have done a full thickness graft for this patient, but again, full thickness graft comes with its own drawbacks. So would like to do always lamellar graft. Even if I have to do a DALC over a DISSEC, I'll prefer the DALC over DISSEC rather than doing a PK graft, because PK has many challenges with it. It's open sky surgery. There is always a risk of intra complication. So a surgery is done, and this graft did very well. Patient has This was the pre-op, and this was 1 year post 1 year post re-DSEC. Patient has 6'9", no astigmatism, and is doing very well. This is the second case, very interesting case. So patient came with a perforated ulcer to me. I did therapeutic keratoplasty and also started steroids after 3 weeks, and graft was clear. Patient came after 3 months. He's 21-year-old chap, and he came with acute graft rejection. I started IV methylprednisolone, did everything whatever could have done. Endothelial rejection, graft could not clear, but graft never cleared. Then I attempted DSEC in this patient. So some of the pearls for these surgeries is you have to. This was around 7.5 mm, 8 mm graft. So I attempted. I think 7.25 was the DSEC size. So you should be at least 1 mm, around 1 mm smaller. Your DSEC graft should be. Otherwise, your graft will overlap with the graft host junction, and which can be sometimes irregular. So graft may detach. So make sure your DSEC graft is smaller than the size, at least 1 mm smaller than the size of your previous PK graft. This was a young patient, and the donor was also, the previous graft which I used was also pretty young, and I had a hard time removing Descemet's membrane for this patient. It took me almost 35 minutes just to remove the Descemet's for this patient, because only there was a graft rejection. But somehow I never use viscoelastics, never use blue for removing Descemet's membrane, but I had to use, and finally it was removed, and then a regular DSEC, same technique, sheath glide, and then made a main tunnel. It is around 4.5 mm, around 5 mm, and then same inserted it, put air bubble and sutured it. So again, I could have attempted a full thickness PK graft in this patient also, but it's much advantageous to use DSEC grafts rather than a PK graft because of the obvious drawbacks of the procedure. And so this was just 2 months post-op. Patient had around 6/18 vision. He's the important thing is it's a phakic eye. So usually we are told that you should do a simultaneous cataract surgery before doing any endothelial keratoplasty, because whenever this patient will develop at some point of time this patient will develop cataract, and that time I'll have to remove this DSEC graft. I'm ready for that, and I've explained the patient. The reason why I did DSEC in this young patient is I wanted to preserve his accommodation for as long as possible, and so that's the reason that I attempted, and probably 5 years or 10 years down the line he will develop cataract, because my patients of generally any transplant surgeries are on lifelong steroids, although he is on lotipred, but still at some point of time he'll develop cataract sooner. That time I'll remove the DSEC graft, do a re-DSEC, and at the same time I'll do a cataract surgery. Thank you.
Any questions from the audience or judges, chairperson?
A query, because I'm dealing with such people, such patients. Re-DSEC, how successful is re-DSEC? Patients who have got interface haze, something like 5 to 7 years after their DSEC, first initial DSEC, if they develop
So
interface,
hardly any
that is hampering vision to the extent of the best corrected visual acuity is right count finger to 660 from 6'9".
So these patients will never reach, DSEC patient hardly reach 6'6". They will be 6'9", 6'12" in most of the cases. There is hardly any haze after 6 months to 8 months. There is no haze, interface haze in these patients. It's not obvious interface haze. That if the patient is reaching 6'9", 6'12", I think it's a pretty good vision for these patients. And it says that.
But that patient, because of the interface haze, is now count finger to 660 after 5 years. So can re-DSEC what you said?
We can, sir. We can. I mean, so like PK, we say that it should not be done more than 3 times, because the risk of failure is much higher in these patients. Whereas I don't know if there is any study of 3-4 DSEC in a single patient, because Probably the DSEC has come in the last 15 years. Probably will times to come we'll know. But I think it should not be a problem for 4 or 5 DSECs in a single patient. It shouldn't be a problem. And if it is, because endothelium is taken care of, and that is the one of the most common cause for a haze. Probably your that patient which you are talking, his endothelium may be failing, maybe DSEC may be failing. Because that's why
the initial basically report that was done in I think Disha Eye Hospital 5 years back.
I mean,
they are noted then only about the interface haze. So that is maybe
maybe a rare case.
हम भेज देंगे, ठीक है.
Thank you, sir.
Thank you so much, sir, for sharing such an valuable video with us. Our next speaker is Dr. Salabh Sinha, sir.
तो खत्म. Thank you so
वो
much.
मोटरसाइकिल चला के चला गया.
And thanks to all the chairperson for this session. Once again, I thanks and congratulate to all the participants who have taken so much pain for today's midterm conference. Now, this is the impromptu scientific committee. May I request the chairman, organic committee, Dr. Raviranjan sir, for valedictory function, and may I request Jai Agarwal sir, ji sir.
यहाँ valedictory करा दो, साथ-साथ बोल देगा ये भी.
हाँ, जी सर. आइए. क्या चाहिए? होम मैसेज एक ही था, टेक होम मैसेज की, जैसे सरकार मुहिम चलाती है फर्स्ट टाइम वोटर, तो हम लोगों ने मोस्टली इस सेशन में इंक्लूड किया था जो हमारे फर्स्ट टाइम स्पीकर. तो आप देखेंगे कि बहुत नए चेहरे होंगे और उसमें से बहुत ने बहुत ही अच्छा प्रेजेंट किया है. इसीलिए साइंटिफिक कमेटी उनको डेफिनेटली अप्रिसिएट करती है और कोशिश करेगी कि आने वाले समय में उनको कुछ अगर सर्टिफिकेट ऑफ मेरिट अवार्ड कुछ दिया जाए. हमारे जजेस जो जज किए होंगे उनको लगा होगा कि कैसा है नहीं है, फिर भी ऑडियंस डेफिनेटली बेनिफिट हुई होंगी इससे. तो थैंक यू सो मच सर.
नहीं, इसमें there is no doubt about it कि the entire team under President sir, the chairman, scientific committee, secretary, everyone has done a wonderful job. ये नया innovation giving an opportunity to young people, हम लोग को भी सीखने का मौका मिलता है, and they also get an opportunity.
At least 30% newer sir.
इस समय मैंने देखा कि बहुत से नए.
So that is a very good concept.
ये सासाराम मेडिकल कॉलेज के बहुत सारे पेपर है जो मैं देख ही रहा था. बहुत अच्छी बात है.
That is going to promote young talent.
ये रीजनल.
थैंक टू डॉक्टर अमरेश जो गया मेडिकल कॉलेज और सासाराम नारायण मेडिकल कॉलेज जितने भी पीजी हमारे हैं एक्टिवली पार्टिसिपेट किए हैं. और
संजीव भी जो है 7-8 पीजी को लेके आया हुआ है, बात हो रही थी पटना से.
नहीं, अच्छा एफर्ट है.